Hello and welcome. If the D454 OA exam has been on your mind and you're wondering how to approach it, then you're in the right place. Our website has D454 OA questions and answers, and it won't cost you a thing. OA exams are tough, so everything from guides to practice questions is free. In this video, we will cover questions from acute emergencies, hematologic disorders, oncology principles, therapeutic modalities, supportive care. So, let's get started.
1. A nurse is caring for a patient admitted with severe epigastric pain, radiating to the back, nausea, and vomiting after a weekend of heavy drinking. The patient asks why they are not allowed to eat. What is the primary rationale for maintaining this dietary restriction? A. To reduce nausea and vomiting episodes. B. To prepare the patient for surgery. C. To rest the inflamed pancreas. D. To prevent aspiration during sedation. Can you guess the answer? Correct answer. C. To rest the inflamed pancreas. Explanation. Option C is correct because maintaining NPO status prevents food from stimulating pancreatic enzyme secretion, allowing the inflamed organ to rest and reducing further autodigestion of pancreatic tissue during the acute episode. Option A is incorrect because while nausea management matters, antiemetics address that symptom directly. The core purpose of withholding food is specifically to stop stimulating the pancreas, not simply to control nausea. Option B is incorrect because most acute pancreatitis cases are managed medically rather than surgically. NPO status in pancreatitis is a therapeutic intervention for pancreatic rest, not routine preoperative preparation. Option D is incorrect because aspiration prevention during sedation is a concern for procedural patients, not the therapeutic rationale for dietary restriction. The primary goal here is reducing stimulation of the pancreas. Alright, let's kick things off with a concept you'll see again and again in pancreatitis questions. NPO status. The patient here has classic acute pancreatitis, severe epigastric pain radiating to the back, nausea, vomiting, and a weekend binge drinking trigger. They want to know why they can't eat. The answer comes down to one thing: pancreatic rest. When food enters the stomach and duodenum, it triggers the release of cholecystokinin and secretin, which tell the pancreas to dump out digestive enzymes. But in acute pancreatitis, those enzymes are already activated inside the gland, eating the tissue alive through autodigestion. Feeding the patient would pour gasoline on that fire. So NPO status isn't about nausea control. Antiemetics handle that separately. It's not surgical prep either, since most pancreatitis cases are managed medically, not in the OR. And it's not about aspiration risk during sedation. That's a procedural concern, not a therapeutic rationale. The whole point is to shut down enzyme secretion so the inflamed pancreas can stop digesting itself. Here's a WGU D454 OA exam tip for you. When you see a pancreatitis question asking about dietary restriction, the answer almost always connects back to reducing pancreatic stimulation. The keyword rest is your signal. Quick recall hook: NPO equal DINS, no pancreatic output. 2. A patient with acute pancreatitis develops muscle twitching, numbness around the mouth, and a positive response when the nurse taps the facial nerve near the cheek. Which electrolyte imbalance is most likely responsible for this cluster of clinical findings? A. Hypocalcemia from fat saponification. B. Hypokalemia from tissue breakdown. C. Hypomagnesemia from poor absorption. D. Hyponatremia from aggressive hydration. Can you guess the answer? Correct answer: A. Hypocalcemia from fat saponification. Explanation. Option A is correct because necrotizing pancreatitis causes fat saponification, which binds calcium, producing hypocalcemia. A positive Chvostek sign with facial twitching and perioral numbness are classic neuromuscular signs of low calcium. Option B is incorrect because hyperkalemia typically presents with cardiac dysrhythmias and muscle weakness rather than facial twitching. Tapping the facial nerve to produce twitching specifically tests for low calcium levels. Option C is incorrect because while hypomagnesemia can cause neuromuscular irritability, the scenario describes a classic Chvostek sign assessment. Combined with pancreatitis, hypocalcemia from fat saponification is the most likely explanation. Option D is incorrect because hyponatremia from aggressive hydration would present with confusion, headache, and altered mental status rather than the specific neuromuscular excitability pattern described in this clinical scenario. This next one tests your ability to connect physical exam findings to electrolyte problems, specifically in pancreatitis. The patient has muscle twitching, perioral numbness, and a positive response when the nurse taps the facial nerve. That tap test is Chvostek's sign, and it's a textbook indicator of hypercalcemia. So why does calcium drop in pancreatitis? During necrotizing pancreatitis, fat tissue breaks down and undergoes saponification. The released fatty acids bind to calcium ions and trap them. The calcium gets locked up in these fatty deposits and becomes unavailable in the blood. Now, hyperkalemia doesn't fit here because potassium problems show up as cardiac dysrhythmias and muscle weakness, not facial twitching from nerve tapping. Hypomagnesemia can cause neuromuscular irritability too, but Chvostek's sign combined with pancreatitis screams calcium, not magnesium. And hyponatremia from aggressive hydration would present with confusion and headache, not this specific twitching pattern. Here's a WGU D454 OA exam tip for you. Whenever you see Chvostek's sign or Trousseau's sign mentioned in a question, your brain should immediately jump to hypocalcemia. Chvostek equals cheek twitch equals calcium crash. That's your recall hook. 3. A nurse assesses a patient with severe pancreatitis and notices bluish discoloration around the belly button and bruising along both flanks. These findings together suggest the patient is developing which dangerous complication that requires immediate escalation of care? A. Pancreatic pseudocyst formation. B. Paralytic ileus with obstruction. C. Peritonitis from perforation. D. Hemorrhagic necrotizing pancreatitis. Can you guess the answer? Correct answer, D. Hemorrhagic necrotizing pancreatitis. Explanation. Option D is correct because Cullen sign at the umbilicus and Gray Turner sign along the flanks together indicate retroperitoneal hemorrhage. This combination is a hallmark finding of hemorrhagic necrotizing pancreatitis requiring urgent intervention. Option A is incorrect because pancreatic pseudocysts present with increasing abdominal pain and distension over time, not with the acute ecchymosis pattern of Cullen and Gray Turner signs that indicate active retroperitoneal bleeding. Option B is incorrect because paralytic ileus presents with abdominal distension, absent bowel sounds, and inability to pass gas. It does not cause the characteristic bruising pattern seen around the umbilicus and flanks. Option C is incorrect because peritonitis from perforation causes rigid board-like abdomen with rebound tenderness. The specific pattern of periumbilical and flank ecchymosis described here points to hemorrhagic pancreatitis instead. Now let's talk about two physical signs that you absolutely must know cold for exam day: Cullen's sign and Gray Turner's sign. The patient here has bluish discoloration around the belly button and bruising along both flanks. That umbilical bruising is Cullen's sign, and the flank bruising is Gray Turner's sign. Together they point to one thing: blood is leaking into the retroperitoneal space. This means hemorrhagic necrotizing pancreatitis. A pseudocyst wouldn't cause this sudden bruising pattern. Pseudocysts build slowly and present with increasing pain and distension. Paralytic ileus gives you distension and absent bowel sounds, not skin ecchymosis. Peritonitis from perforation causes a rigid, board-like abdomen with rebound tenderness, which is a completely different presentation. The bruising pattern is the giveaway. Blood is tracking through tissue planes from the retroperitoneum to the skin surface. Here's a WGU D454 OA exam tip for you. If you see periumbilical bruising and flank bruising together in any question, the answer is hemorrhagic pancreatitis. Every single time. Recall hook. Cullen's is around the belly button, think C for centre. Gray Turner's is on the flanks, think T for turning to the sides. 4. A patient with chronic pancreatitis reports persistent weight loss despite eating regular meals and describes pale, greasy, foul-smelling stools that float in the toilet. Which intervention should the nurse anticipate as the priority to address this specific malabsorption problem? A. Starting total parenteral nutrition. B. Administering pancreatic enzyme supplements with meals. C. Placing a nasogastric tube for feeding. D. Restricting all dietary fat permanently. Do you know the answer? Correct answer, B. Administering pancreatic enzyme supplements with meals. Explanation. Option B is correct because steatorrhea in chronic pancreatitis results from inadequate pancreatic lipase production. Pancrelipase supplements taken with every meal and snack replace missing enzymes and restore the ability to digest fats properly. Option A is incorrect because total parenteral nutrition bypasses the gastrointestinal tract entirely and is reserved for patients who cannot tolerate any enteral feeding. Enzyme replacement allows normal oral nutrition to continue. Option C is incorrect because nasogastric tube feeding does not solve the underlying enzyme deficiency problem. Without pancreatic enzymes, the patient cannot properly digest nutrients regardless of how the food is delivered. Option D is incorrect because permanently eliminating all dietary fat would worsen nutritional deficiencies and is unnecessary. A low-fat diet combined with enzyme supplementation allows adequate fat absorption and maintains proper nutrition. This question zeroes in on chronic pancreatitis and its hallmark GI problem, steatorrhea. The patient is losing weight despite eating, and their stools are pale, greasy, foul-smelling and float. That floating, fatty stool happens because the pancreas is too damaged to produce enough lipase to break down dietary fat. The fat passes through undigested, so the fix is straightforward. Replace the missing enzymes. Pancrelipase supplements taken with every meal and snack give the gut what the pancreas no longer can. TPN is way too aggressive here. That's for patients who can't tolerate any enteral feeding at all, and this patient is eating just fine. They just can't digest fat. An NG tube doesn't solve the problem either, because the issue isn't delivery of food. You could pump food into the stomach all day, and without enzymes the fat still won't get digested. And permanently cutting out all fat, that's both unnecessary and harmful. A low-fat diet with enzyme supplements is the right balance. Here's a WGU D454 OA exam tip for you. Steatorrhea plus chronic pancreatitis equals pancrelipase every time. The recall hook, STAT, stands for supplement the enzymes and treat. And 5. A nurse is teaching a patient being discharged after their second acute pancreatitis episode caused by gallstones. The patient asks what they can do to prevent future attacks. Which response by the nurse addresses the most likely definitive intervention? A. Surgical removal of the gallbladder. B. Lifelong proton pump inhibitor therapy. C. Strict adherence to a clear liquid diet. D. Daily oral pancreatic enzyme supplements. Can you guess the answer? Correct answer, A. Surgical removal of the gallbladder. Explanation? Option A is correct because cholecystectomy is the definitive treatment for gallstone pancreatitis. Removing the gallbladder eliminates the source of stones that obstruct the common bile duct and trigger recurrent pancreatic inflammation. Option B is incorrect because proton pump inhibitors reduce gastric acid and may be used as adjunctive therapy, but they do not address gallstones. Without removing the source, stones will continue causing recurrent episodes. Option C is incorrect because a clear liquid diet is a temporary measure during acute recovery, not a long-term prevention strategy. Patients can resume a low-fat diet after recovery while addressing the underlying gallstone cause. Option D is incorrect because pancreatic enzyme supplements treat the malabsorption complications of chronic pancreatitis. They do not prevent gallstones from forming or blocking the duct, which is the cause of this patient's episodes. Here we've got a patient on their second round of gallstone pancreatitis, asking how to stop it from happening again. The answer is cholecystectomy, removing the gallbladder. If gallstones are causing the pancreatitis, you have to eliminate the source. Stones form in the gallbladder, migrate into the common bile duct, and block the pancreatic duct where it joins. That backup triggers the whole inflammatory cascade. Remove the gallbladder, remove the stone factory, prevent future episodes. Proton pump inhibitors reduce stomach acid, which can be useful adjunctively, but they do nothing about gallstones sitting in your biliary system. A clear liquid diet is a temporary recovery measure, not a long-term prevention plan. You can't live on clear liquids forever, and even if you could, stones would still form. Pancreatic enzyme supplements treat the complications of chronic pancreatitis, like malabsorption. They don't prevent stones from blocking ducts. Here's a WGU D454 OA exam tip for you. When a question mentions recurrent pancreatitis caused by gallstones and asks about definitive prevention, cholecystectomy is your answer. Recall hook. Gallstones cause it? Remove the gallery. Cholecystectomy is the gallery removal. 6. A nurse is performing a routine abdominal assessment on an older male patient and detects a pulsatile mass above the umbilicus along with a systolic bruit on auscultation. The patient denies pain. Which condition do these findings most strongly suggest the nurse should investigate further? A. Intestinal obstruction with distension. B. Hepatomegaly from chronic liver disease. C. Inguinal hernia with bowel involvement. D. Abdominal aortic aneurysm expanding silently. What do you think is the answer? Correct answer. D. Abdominal aortic aneurysm expanding silently. Explanation. Option D is correct because a pulsatile abdominal mass above the umbilicus combined with a systolic bruit is the classic presentation of an abdominal aortic aneurysm. Many patients remain asymptomatic until significant expansion occurs. Option A is incorrect because intestinal obstruction presents with hyperactive or high-pitched bowel sounds, abdominal distension, and cramping pain. A pulsatile mass with a bruit is not characteristic of bowel obstruction. Option B is incorrect because hepatomegaly presents as a palpable liver edge in the right upper quadrant, not as a pulsatile midline abdominal mass. Liver enlargement does not produce the characteristic systolic bruit heard here. Option C is incorrect because inguinal hernias are located in the groin region, not above the umbilicus. They present as a bulge that may increase with straining, not as a pulsatile mass with an auscultated bruit. Picture this. You're doing a routine abdominal assessment on an older gentleman, and you feel something pulsing above his belly button. You listen with your stethoscope and hear a systolic bruit. He says he feels fine, no pain at all. That pulsatile mass with a bruit is the classic finding of an abdominal aortic aneurysm. The aorta runs down the centre of the abdomen, and when its wall weakens and bulges outward, you can feel it pushing with each heartbeat. The bruit comes from turbulent blood flow through the dilated segment. Most defibrillates are completely silent until they get dangerously large or rupture. Now, intestinal obstruction gives you hyperactive, high-pitched bowel sounds and cramping, not a pulsatile mass. Hepatomegaly sits in the right upper quadrant and doesn't pulse in the midline. An inguinal hernia is in the groin, nowhere near the supraumbilical area. Here's a WGU D454 OA exam tip for you. Pulsatile abdominal mass plus brute equals AAA until proven otherwise. The word pulsatile is the dead giveaway. Recall hook. Pulsatile above belly button means PAB. And AAA has 3 letters too. Pulsatile mass, think AAA. 7. A patient with a known abdominal aortic aneurysm suddenly reports severe tearing pain in their back and abdomen. Their blood pressure drops rapidly, heart rate increases and the skin becomes cold and clammy. What is the nurse's immediate priority action? A. Administer prescribed antihypertensive medications. B. Notify the provider and prepare for emergency surgery. C. Position the patient flat and elevate the legs. D. Obtain a complete set of laboratory studies. Do you know the answer? Correct answer, B. Notify the provider and prepare for emergency surgery. Explanation. Option B is correct because sudden tearing pain with hypertension, tachycardia, and diaphoresis in a patient with known aneurysm indicates likely rupture. This carries greater than 90% mortality without emergency surgical intervention immediately. Option A is incorrect because administering antihypertensives to a patient who is already hypertensive from hemorrhagic shock would further decrease blood pressure and worsen organ perfusion. The priority is surgical repair of the rupture. Option C is incorrect because while positioning is a supportive measure, it alone cannot address the life-threatening internal hemorrhage from a ruptured aneurysm. Definitive surgical intervention is the priority over positioning. Option D is incorrect because obtaining laboratory studies, while ultimately necessary, takes time that this critically unstable patient does not have. Delaying notification for labs wastes precious minutes before life-saving surgery. This one is a true emergency. A patient with a known AAA suddenly develops severe tearing pain in the back and abdomen. Their blood pressure tanks, heart rate shoots up, and they go cold and clammy. That's a ruptured AAA with hemorrhagic shock, and without emergency surgery, the mortality rate exceeds 90%. There is no time to waste. The nurse's immediate priority is notifying the provider and preparing for emergency surgery. Now look at the distractors and see why they fail. Giving antihypertensives to a patient who is already hypertensive from internal bleeding. That would drop their pressure further and kill them faster. Positioning with legs elevated is a supportive measure, but it cannot stop a torn aorta from hemorrhaging. And yes, labs will be needed eventually, but stopping to draw blood when the patient is actively exsanguinating wastes time that could be spent getting them to the OR. Here's a WGU D454 OA exam tip for you. Tearing pain plus hypertension plus tachycardia plus known aneurysm equals rupture equals emergency surgery. There is no conservative option. Recall hook, a TR. TIR means time for emergency aortic repair. 8. A nurse is providing discharge education to a patient with a small stable abdominal aortic aneurysm being managed conservatively. The patient asks what single lifestyle change would have the greatest impact on slowing the growth of their aneurysm over time. A. Following a strict low-sodium diet. B. Beginning a daily walking exercise program. C. Quitting smoking completely and permanently. D. Reducing daily caffeine intake significantly. What do you think is the answer? Correct answer, C. Quitting smoking completely and permanently. Explanation. Option C is correct because smoking cessation is the single most important modifiable intervention to slow aneurysm growth. Smoking directly weakens arterial walls through inflammatory damage and accelerates the atherosclerotic process that drives expansion. Option A is incorrect because while a low-sodium diet supports blood pressure management, it has less direct impact on aneurysm progression than smoking cessation. Option B is incorrect because moderate exercise is beneficial for cardiovascular health overall, but it does not directly slow aneurysm growth. Option D is incorrect because reducing caffeine intake has minimal evidence supporting its role in slowing aneurysm growth. A patient with a small, stable AAA asks what single lifestyle change matters most. The answer is smoking cessation, and it's not even close. Smoking directly damages arterial walls through chronic inflammation, accelerates atherosclerosis, and promotes elastin degradation, the very protein that keeps the aortic wall elastic and strong. Every cigarette is chemically weakening the wall that's already bulging. A low-sodium diet helps blood pressure, sure, but it's an indirect effect and secondary to quitting tobacco. Exercise improves cardiovascular health generally, but walking doesn't undo the structural damage smoking causes to vessel walls. And cutting caffeine? The evidence there is thin. Caffeine gives you a temporary BP bump, but its effect on aneurysm progression is negligible compared to the wrecking ball that smoking represents. Here's a WGU D454 OA exam tip for you. If an AAA question asks about the single most important lifestyle change, the answer is always smoking cessation. The word single is your cue. Smoking is the biggest modifiable factor. Recall hook. Smoking stops the strength of the aortic wall. SSS. Stop smoking to save the wall. 9. Following endovascular aneurysm repair, a nurse assesses the patient and finds the right foot is cold, pale and pulseless, while the left foot remains warm with strong pulses. Which post-operative complication does this asymmetric finding most strongly indicate? A. Thromboembolism causing acute limb ischemia. B. Endoleak at the stent graft site. C. Acute renal failure from contrast exposure. D. Mesenteric ischemia from clamp injury. Do you know the answer? Correct answer. A. Thromboembolism causing acute limb ischemia. Explanation. Option A is correct because a cold, pale, pulseless extremity on one side after endovascular repair strongly indicates thromboembolism, obstructing arterial blood flow to that limb. This requires urgent intervention to restore circulation. Option B is incorrect because an endoleak involves blood seeping around or through the graft and typically presents with persistent back or abdominal pain and hemodynamic changes, not isolated unilateral loss of pulses in one extremity. Option C is incorrect because acute renal failure from contrast dye presents with decreased urine output and rising creatinine levels. It does not cause the unilateral cold, pale, pulseless extremity pattern described in this scenario. Option D is incorrect because mesenteric ischemia affects the intestinal blood supply and presents with severe abdominal distension, absent bowel sounds, and metabolic acidosis rather than asymmetric lower extremity pulse findings. After an endovascular aneurysm repair, you check the patient's feet and find the right foot is cold, pale and pulseless, while the left foot is warm with strong pulses. That asymmetry is the key finding. One side has blood flow, the other doesn't. This screams thromboembolism, causing acute limb ischemia. During the EVAR procedure, a catheter is threaded through the femoral artery. Clot fragments or plaque can dislodge and travel downstream, plugging the arterial supply to one leg. An endoleak is blood seeping around the graft, which causes persistent back or abdominal pain and hemodynamic instability, not isolated loss of pulses in one foot. Renal failure from contrast dye shows up as decreased urine output and rising creatinine, not limb perfusion changes. Mesenteric ischemia affects the gut. You'd see severe distension, absent bowel sounds, and metabolic acidosis. Here's a WGU D454 OA exam tip for you. Cold, pale, pulseless limb after vascular surgery equals thromboembolism. Look for the word asymmetric or one-sided findings. That's your trigger. Recall hook, the 6 P's of acute limb ischemia. Pain, pallor, pulselessness, paresthesia, paralysis, poikilothermia. 10. A nurse is reviewing risk factors with a patient newly diagnosed with a small abdominal aortic aneurysm. The patient is a male over age 65 with a long smoking history, high cholesterol, and uncontrolled high blood pressure. Which screening recommendation applies to this patient's demographic? A. Annual chest radiograph for all men over 50. B. Colonoscopy screening every 5 years after diagnosis. C. Cardiac stress testing annually, regardless of symptoms. D. One-time abdominal ultrasound for male smokers over 65. Do you know the answer? Correct answer, D. One-time abdominal ultrasound for male smokers over 65. Explanation. Option D is correct, because national screening guidelines recommend a one-time abdominal ultrasound for men aged 65 and older with any smoking history. This targeted screening detects asymptomatic aneurysms before rupture occurs. Option A is incorrect because annual chest radiographs are not a standard recommendation for abdominal aortic aneurysm screening. Chest films evaluate thoracic structures but cannot reliably detect or measure abdominal aortic dilation. Option B is incorrect because colonoscopy is a colorectal cancer screening tool and has no role in monitoring or detecting abdominal aortic aneurysms. These are entirely separate screening programs with different target conditions. Option C is incorrect because annual cardiac stress testing, regardless of symptoms, is not a standard screening recommendation for aneurysm patients. Stress testing evaluates coronary artery perfusion, not the structural integrity of the aorta. This question is about screening guidelines, and it's a straight factual recall item. National guidelines recommend a one-time abdominal ultrasound screening for men aged 65 and older who have any history of smoking. That's it. One ultrasound, one time, for that specific demographic. The rationale is that ABIAs are most common in older men with smoking histories, and catching an aneurysm before it ruptures dramatically improves survival. Screening detects the silent ones that would otherwise blow without warning. Annual chest x-rays aren't part of AAA screening. A chest film looks at the thorax, not the abdomen. Colonoscopy is for colorectal cancer, a completely different screening program. Annual cardiac stress testing, regardless of symptoms, isn't standard for aneurysm patients. Stress tests evaluate coronary perfusion, not aortic wall integrity. Here's a WGU D454 OA exam tip for you. Memorize this screening guideline exactly. Men, 65 plus, smoking history, one-time abdominal ultrasound. Exams love to test whether you know it's a one-time screen, not annual. Recall hook. One time, one ultrasound for the one highest risk group, older male smokers. 11. A patient arrives at the emergency department reporting they accidentally took too much acetaminophen over the past 2 days by combining a cold medication with a separate headache remedy. They currently feel fine with no symptoms. Why is immediate treatment still critically important? A. Pain will rapidly worsen without intervention. B. Liver damage progresses silently in early stages. C. Kidney failure develops before any symptoms appear. D. Cardiac toxicity occurs within the first hour. Can you guess the answer? Correct answer, B. Liver damage progresses silently in early stages. Explanation. Option B is correct because stage 1 of acetaminophen toxicity is often completely asymptomatic, while the toxic metabolite NAPQ is already actively destroying hepatocytes. Waiting for symptoms delays life-saving treatment during the critical intervention window. Option A is incorrect because acetaminophen overdose does not typically cause worsening pain as an early symptom. The dangerous progression involves silent liver destruction rather than escalating pain that would prompt the patient to seek care. Option C is incorrect because while renal failure can occur in advanced stages of acetaminophen toxicity, it develops later as part of multi-organ failure. The primary early silent damage occurs in the liver, not the kidneys. Option D is incorrect because acetaminophen toxicity primarily targets the liver through the toxic metabolite NAPQI, not the heart. Cardiac toxicity within the first hour is not a recognized pattern of acetaminophen poisoning. This is a sneaky one, and it tests whether you understand the most dangerous thing about acetaminophen overdose: the silence. This patient combined a cold remedy with a headache tablet for 2 days, accidentally stacking acetaminophen, and they feel completely fine right now. Stage 1 of acetaminophen toxicity is the deceptive stage. The patient may have 0 symptoms or maybe some mild nausea, but behind the scenes, NAPQI, the toxic metabolite, is already chewing through hepatocytes. By the time symptoms actually show up in stage 2 or 3, massive liver damage has already occurred, and the window for effective treatment is closing. That's why treatment can't wait for symptoms. Pain worsening isn't the early pattern. This isn't a condition that announces itself with escalating discomfort. Kidney failure can happen, but it's a late-stage development from multi-organ failure, not the primary early silent injury. And cardiac toxicity within the first hour? That's not how acetaminophen works. It's a liver toxin, not a cardiotoxin. Here's a WGU D454 OA exam tip for you. If a question describes an asymptomatic patient with acetaminophen overdose and asks why treatment is urgent, the answer is always silent liver damage. The word asymptomatic in an overdose question is a red flag, not reassurance. Recall hook, silent stage, sneaky NAPQI. 12. A nurse understands that N-acetylcysteine is the specific antidote for acetaminophen overdose. A colleague asks how this medication actually works at the cellular level to protect the liver from ongoing damage caused by the toxic metabolite produced during overdose. A. It replenishes glutathione to neutralize NAPQI. B. It blocks the CYP enzyme pathway completely. C. It directly binds acetaminophen in the bloodstream. D. It stimulates rapid hepatocyte cell regeneration. Do you know the answer? Correct answer, A. It replenishes glutathione to neutralize NAPQI. Explanation: Option A is correct because N-acetylcysteine serves as a glutathione precursor, restoring the depleted stores needed to conjugate and neutralize the toxic metabolite NAPQI before it can cause further oxidative damage to liver cells. Option B is incorrect because N-acetylcysteine does not completely block the CYP enzyme pathway. The drug works downstream by replenishing glutathione stores that neutralize NAPQI after it has already been produced by the CYP system. Option C is incorrect because N-acetylcysteine does not bind circulating acetaminophen molecules directly in the bloodstream. Its mechanism involves restoring the liver's own detoxification capacity through glutathione replenishment rather than drug binding. Option D is incorrect because N-acetylcysteine does not stimulate hepatocyte regeneration. While the liver can regenerate over time, if enough viable cells survive, the antidote works by preventing further damage rather than growing new cells. Now let's break down exactly how NAC, N-acetylcysteine, saves the liver. Under normal conditions, a small percentage of acetaminophen gets processed through the CYP450 enzyme system, producing NAPQI. Normally glutathione swoops in and neutralizes NAPQI before it can do damage. But in an overdose, glutathione stores get depleted because there's just too much NAPQI being produced. ANEC works by serving as a glutathione precursor. It gives the liver the raw material to rebuild its glutathione supply, which then resumes neutralizing NAPQI. It does not block the CYP pathway entirely. The pathway is still running. ANEC works downstream, cleaning up the mess after NAPQI is made. It doesn't bind acetaminophen molecules floating in the blood. That's not how it operates. And it doesn't regenerate liver cells. The liver can regenerate on its own over time if enough cells survive. But NAC's job is preventing further damage, not growing new tissue. Here's a WGU D454 OA exam tip for you. NAC equals glutathione replenishment. If a question asks about the mechanism of NAC, glutathione is always in the correct answer. Recall hook, ENaC nourishes the antidote called glutathione. 13. A patient with acetaminophen overdose is now 72 hours post-ingestion and develops confusion, a flapping hand tremor when extending their wrists, and progressive lethargy. Which medication should the nurse anticipate administering to address the underlying cause of these neurological symptoms? A. Naloxone for suspected opioid effects. B. Flumazenil for benzodiazepine reversal. C. Dextrose for acute hypoglycemia correction. D. Lactulose for elevated ammonia levels. What do you think is the answer? Correct answer, D. Lactulose for elevated ammonia levels. Explanation. Option D is correct because confusion with asterixis at 72 hours indicates hepatic encephalopathy from the failing liver's inability to clear ammonia. Lactulose promotes ammonia excretion through the stool to reduce toxic brain levels. Option A is incorrect because naloxone reverses opioid effects and would be appropriate for respiratory depression from narcotics. The asterixis and progressive confusion pattern here indicates hepatic encephalopathy, not opioid toxicity. Option B is incorrect because flumazenil reverses benzodiazepine sedation and is not indicated here. The specific finding of asterixis combined with confusion in a liver failure patient points to ammonia accumulation, not sedative overdose. Option C is incorrect because while hypoglycemia can occur in liver failure and cause confusion, the specific finding of asterixis strongly points to hepatic encephalopathy from ammonia buildup. Dextrose alone would not address the flapping tremor. 72 hours after an acetaminophen overdose, the patient becomes confused, lethargic, and develops a flapping hand tremor when extending their wrists. That flapping tremor has a specific name: asterixis. And it's the hallmark sign of hepatic encephalopathy. Here's what's happening. The liver is failing. When the liver stops working, it can no longer clear ammonia from the bloodstream. Ammonia is a neurotoxin, and as levels climb, the brain starts to shut down. Confusion comes first, then asterixis, then deeper obtundation, and eventually coma. Lactulose is the treatment. It works in the gut by drawing ammonia into the colon and trapping it there so it gets excreted in stool rather than crossing into the brain. Naloxone reverses opioids. You'd see pinpoint pupils and respiratory depression, not asterixis. Flumazenil reverses benzodiazepines. Again, wrong clinical picture. Dextrose treats hypoglycemia, which can cause confusion in liver failure, but dextrose alone won't produce the asterixis finding. That flapping tremor is your key differentiator. Here's a WGU D454 OA exam tip for you. Asterixis in a liver failure patient always points to hepatic encephalopathy, and the treatment is always lactulose. Recall hook. Asterixis means ammonia, and lactulose lowers it. 14. A patient in stage 3 acetaminophen toxicity has an extremely elevated INR and develops active bleeding from multiple sites. The nurse understands that immediate clotting factor replacement is needed. Which blood product provides the fastest correction of this life-threatening coagulopathy? A. Packed red blood cells for volume replacement. B. Vitamin K injection for clotting factor synthesis. C. Fresh frozen plasma for immediate clotting factors. D. Platelet transfusion for hemostasis support. Can you guess the answer? Correct answer, C. Fresh frozen plasma for immediate clotting factors. Explanation. Option C is correct because fresh frozen plasma contains all clotting factors and provides immediate correction of coagulopathy. In acute liver failure with active bleeding, the liver cannot synthesize factors, making direct replacement essential. Option A is incorrect because packed red blood cells replace oxygen carrying capacity and volume, but contain no clotting factors. They address anemia from blood loss but do not correct the underlying coagulopathy causing continued bleeding. Option B is incorrect because vitamin K requires a functioning liver to synthesize clotting factors and takes hours to produce an effect. In acute liver failure, the hepatocytes needed to respond to vitamin K are already destroyed. Option D is incorrect because platelet transfusion addresses thrombocytopenia but does not replace the clotting factors that are deficient due to liver failure. The elevated INR specifically reflects clotting factor depletion, requiring plasma replacement. A patient in stage 3 acetaminophen toxicity has an INR through the roof and is bleeding from multiple sites. This is a coagulopathy emergency. The liver is so damaged it cannot produce clotting factors. The question asks what provides the fastest correction. Fresh frozen plasma is the answer. FFP contains every clotting factor the blood needs, and it works within minutes of infusion. Because you're giving pre-made factors directly, no synthesis required. Packed red blood cells replace oxygen carrying capacity and volume, but they contain zero clotting factors. They address the anemia from blood loss, but for not the bleeding itself. Vitamin K sounds logical because the liver uses it to make clotting factors. But here's the problem. Vitamin K requires a functioning liver to convert it into active factors. If the liver is destroyed, vitamin K has nothing to work with, and it takes hours even in the best case. Platelet transfusion addresses thrombocytopenia specifically, but the elevated INR here reflects clotting factor depletion, not a platelet problem. Here's a WGU D454 OA exam tip for you. Elevated INR plus active bleeding plus liver failure equals FFP, not vitamin K. The key distinction is speed. FFP is immediate, vitamin K is slow and liver dependent. Recall hook. FFP means factors for the patient right now. 15. A nurse is providing community education about acetaminophen safety. A participant mentions they regularly take a nighttime cold remedy and a separate headache tablet, both purchased without prescription. What is the most important safety teaching point for this individual? A. Check all product labels for hidden acetaminophen. B. Always take medications with a full glass of milk. C. Limit cold medication, use to 5 days maximum. D. Switch to prescription-only pain relief options. Can you guess the answer? Correct answer. A. Check all product labels for hidden acetaminophen. Explanation. Option A is correct because unintentional overdose commonly occurs when patients combine multiple over-the-counter products that each contain acetaminophen without realizing the cumulative dose exceeds the safe daily maximum of 4 grams. Option B is incorrect because taking medications with milk is a general administration tip for some drugs but does not address the core danger. The critical safety issue is unknowingly exceeding acetaminophen limits through combination products. Option C is incorrect because while limiting cold medication duration is reasonable general advice, it does not address the immediate overdose risk. A person could exceed toxic doses within a single day by combining acetaminophen-containing products. Option D is incorrect because switching to prescription options does not inherently prevent acetaminophen toxicity. Many prescription pain medications also contain acetaminophen, and the key issue is awareness of total intake from all sources. This is a community education question about acetaminophen safety, and it targets the most common cause of unintentional overdose: hidden acetaminophen in combination products. The person here is taking a nighttime cold remedy and a separate headache tablet, both over the counter. Many cold, flu and pain products contain acetaminophen buried in the ingredient list under names like APAP. If you're taking 2 or 3 of these products simultaneously, you can easily blow past the 4-gram daily limit without realizing it. The most important teaching point is to check every product label for acetaminophen content. Taking medications with milk is a general tip for some drugs, but completely misses the core danger. Limiting cold medication to 5 days is reasonable general advice, but you could exceed toxic doses within a single day by stacking products. Switching to prescription options doesn't fix the problem either. Many prescription pain meds also contain acetaminophen. Here's a WGU D454 OA exam tip for you. Unintentional acetaminophen. Overdose questions always circle back to label reading and identifying hidden acetaminophen in combination products. Recall hook. Hidden acetaminophen harms. Ha. Always check labels. 16. A nurse is caring for a patient diagnosed with iron deficiency anemia who has been prescribed oral ferrous sulfate supplements. The patient asks about the best way to take the medication to get the most benefit. Which instruction promotes maximum absorption of the oral iron supplement? A. Take with antacids to reduce stomach upset. B. Swallow with a glass of whole milk daily. C. Combine with calcium-rich foods at mealtimes. D. Drink with orange juice on an empty stomach. Do you know the answer? Correct answer. D. Drink with orange juice on an empty stomach. Explanation. Option D is correct because vitamin C in orange juice enhances iron absorption in the duodenum, and taking iron on an empty stomach prevents food interactions that reduce bioavailability. Option A is incorrect because antacids raise gastric pH and significantly reduce iron absorption. Iron requires an acidic stomach environment for optimal absorption, and antacids directly oppose this requirement by neutralizing stomach acid. Option B is incorrect because dairy products contain calcium, which directly competes with iron for absorption in the intestinal lining. Whole milk would significantly decrease the amount of iron the body can absorb from the supplement. Option C is incorrect because calcium-rich foods inhibit iron absorption through competitive binding at intestinal absorption sites. Taking iron supplements away from calcium-containing foods and dairy products maximizes the therapeutic benefit. Iron absorption. This is a pharmacology staple. The patient has iron deficiency anemia and wants to know how to get the most out of their ferrous sulfate supplement. The answer is to take it with orange juice on an empty stomach. Two things are at play. First, vitamin C from the orange juice converts ferric iron to ferrous iron in the gut, making it much more absorbable. Second, an empty stomach, about 1 hour before meals, keeps the iron away from food components that block absorption. Now look at what kills iron absorption. Antacids raise the gastric pH, and iron needs an acidic environment to dissolve properly. Antacids directly sabotage that. Dairy products contain calcium, which competes with iron at the absorption sites in the intestinal lining. A glass of milk with your iron supplement means the calcium grabs the transport spots iron needs. Calcium-rich foods do the same thing. Competitive binding. Here's a WGU D454 OA exam tip for you. Iron plus vitamin C plus empty stomach equals maximum absorption. If you see antacids, dairy or calcium paired with iron, in any answer choice, that's the wrong answer. Recall hook. OJ on an empty jummy. OJ is iron's best friend. 17. A patient with pernicious anemia asks why they cannot simply eat more liver and red meat to correct their vitamin B12 deficiency instead of receiving injections for the rest of their life. Which explanation by the nurse best addresses the underlying pathophysiology of this condition? A. Dietary sources contain insufficient amounts of B12. B. The stomach lacks intrinsic factor needed for absorption. C. The bone marrow cannot process B12 from food sources. D. Liver disease prevents storage of ingested B12 vitamins. What do you think is the answer? Correct answer. B. The stomach lacks intrinsic factor needed for absorption. Explanation. Option B is correct because pernicious anemia results from the inability to produce intrinsic factor by gastric parietal cells. Without intrinsic factor, B12 cannot be absorbed in the terminal ileum regardless of dietary intake. Option A is incorrect because liver and red meat actually contain substantial amounts of vitamin B12. The problem in pernicious anemia is not insufficient dietary content, but rather the inability to absorb B12 from the gastrointestinal tract. Option C is incorrect because the bone marrow can process B12 normally once it reaches the bloodstream through injection. The defect in pernicious anemia is at the absorption level in the gut, not at the bone marrow utilization level. Option D is incorrect because pernicious anemia is not caused by a liver storage problem. The liver can store B12 adequately when it is delivered via injection, confirming that the defect lies in gastrointestinal absorption, not hepatic storage. The patient with pernicious anemia wants to know why eating more liver and red meat won't fix their B12 deficiency. It's a fair question, and the answer lies in intrinsic factor. Pernicious anemia means the gastric parietal cells have stopped producing intrinsic factor, the protein that B12 must bind to before it can be absorbed in the terminal ileum. Without that protein escort, B12 just passes through the gut and gets excreted. You could eat a pound of liver every day, and none of it would get absorbed. That's why treatment requires lifelong intramuscular injections or intranasal spray, routes that bypass the gut entirely. Diet isn't the problem here. Liver and red meat are loaded with B12. The bone marrow can process B12 perfectly well once it reaches the bloodstream through injection. The defect isn't at the marrow level, and liver storage is fine too. The liver stores B12 normally when delivered via injection. The entire defect is at the absorption step in the gut. Here's a WGU D454 OA exam tip for you. Pernicious anemia equals intrinsic factor deficiency. If a question pairs pernicious anemia with dietary solutions, that's the wrong answer. Recall hook, no if, no absorption. Intrinsic factor is the gatekeeper. 18. A nurse reviews the chart of a patient with polycythemia vera and notes significantly elevated hemoglobin and hematocrit values along with complaints of headaches and blurred vision. Which treatment does the nurse anticipate as the primary intervention to reduce this patient's dangerously thickened blood? A. Iron supplement administration to balance production. B. Aggressive intravenous fluid hydration therapy. C. Therapeutic phlebotomy to reduce blood volume. D. Immediate platelet transfusion for viscosity control. What do you think is the answer? Correct answer, C. Therapeutic phlebotomy to reduce blood volume. Explanation. Option C is correct because therapeutic phlebotomy directly removes excess red blood cells, reducing blood viscosity and volume. This is the primary treatment for polycythemia vera and quickly lowers the dangerous thrombosis risk. Option A is incorrect because iron supplements would stimulate additional red blood cell production, worsening the already dangerously elevated cell counts. Iron supplementation is specifically avoided in polycythemia vera to prevent further overproduction. Option B is incorrect because while hydration is supportive, aggressive fluid administration alone does not adequately reduce the pathologically elevated red blood cell mass. Therapeutic phlebotomy is required to physically remove the excess cells. Option D is incorrect because platelet transfusion would add more cellular components to already thickened blood, potentially increasing clotting risk. Polycythemia vera management focuses on removing excess cells, not adding blood products. Polycythemia vera, too many red blood cells. The patient has elevated hemoglobin and hematocrit, headaches and blurred vision. Their blood is thick like sludge, and the risk of blood clots is through the roof. The treatment is therapeutic phlebotomy, literally removing blood from the body to thin it out. You're draining off the excess red cells to reduce viscosity and lower clot risk. Now watch the distractors try to trick you. Iron supplements in polycythemia vera. That's backwards. Iron would stimulate even more red cell production in a patient who already has too many. Iron is specifically avoided. Aggressive IV fluids dilute the blood temporarily, but don't remove the excess cells. The problem is too many red blood cells, not too little fluid. And platelet transfusion, you'd be adding more cellular components to already thick blood, making the clotting risk worse. Here's a WGU D454 OA exam tip for you. Polycythemia vera equals too many red cells, and the treatment is phlebotomy to remove them. If you see iron supplements as an answer choice in a polycythemia question, cross it out immediately. Recall hook. Poly means many. Phlebotomy means removing. Too many cells? Remove them. 19. A patient with aplastic anemia has severely reduced counts of all blood cell lines. The nurse is planning care assignments and needs to select the safest roommate for this immunocompromised patient. Which of the following patients would be most appropriate to room with this individual? A. A patient recovering from severe heart failure. B. A patient being treated for bacterial cellulitis. C. A patient with active viral pneumonia symptoms. D. A patient receiving antibiotics for a wound infection. Do you know the answer? Correct answer, A. A patient recovering from severe heart failure. Explanation. Option A is correct because heart failure is a non-infectious condition that poses no transmission risk to the immunocompromised patient. Aplastic anemia patients need protection from all potential infectious exposures during their vulnerable state. Option B is incorrect because bacterial cellulitis is an active skin infection that could potentially transmit bacteria to the immunocompromised roommate. Even with contact precautions, exposing an aplastic anemia patient to active infection is unsafe. Option C is incorrect because viral pneumonia is a respiratory infection spread through droplets and aerosols. Placing an immunocompromised patient with severely reduced white blood cells near an actively infectious respiratory patient risks fatal infection. Option D is incorrect because a patient receiving antibiotics for an active wound infection still harbours potentially harmful organisms. The aplastic anemia patient's severely depressed immune system cannot fight even minor bacterial exposures effectively. Room assignments for immunocompromised patients. This comes up on exams more often than you'd expect. The patient has aplastic anemia, which means pancytopenia. Low white cells, low red cells, low platelets. Their immune system is severely depressed. You need to pick the safest roommate. The answer is the patient recovering from severe heart failure, because heart failure is not an infectious condition. There's nothing transmissible about a weakened heart. Now look at the other options. Bacterial cellulitis is an active skin infection. Bacteria could spread to your immunocompromised patient, even with precautions. Viral pneumonia is a respiratory infection spread through droplets, and putting a neutropenic patient in the same room as someone coughing up virus particles is asking for disaster. A patient on antibiotics for a wound infection still has active organisms. The antibiotics are fighting the infection. They haven't eliminated it yet. Here's a WGU D454 OA exam tip for you. For room assignment questions, your job is to pick the patient with a non-infectious condition. Scan the options and eliminate every choice with any active infection, bacterial, viral or otherwise. Recall hook. Immunocompromised gets the non-infectious neighbour. 20. A nurse is caring for a patient with sickle cell disease who presents during a vaso-occlusive crisis with severe pain in multiple joints and extremities. After administering prescribed opioid analgesics, which nursing action takes highest priority in ongoing crisis management? A. Applying cold packs to the affected joints. B. Restricting fluid intake to prevent overload. C. Encouraging active range of motion exercises immediately. D. Evaluating the effectiveness of pain medication given. Do you know the answer? Correct answer. D. Evaluating the effectiveness of pain medication given. Explanation. Option D is correct because during a sickle cell vaso-occlusive crisis, the priority nursing intervention after administering opioids is evaluating their effectiveness. Adequate pain control is the cornerstone of crisis management and drives ongoing treatment decisions. Option A is incorrect because cold application causes vasoconstriction, which worsens sickling by reducing blood flow and oxygen delivery to tissues. Cold packs are contraindicated during vaso-occlusive crisis because they promote further sickling of cells. Option B is incorrect because fluid restriction is the opposite of what sickle cell crisis patients need. Aggressive intravenous hydration is essential to improve blood flow, reduce viscosity, and prevent further sickling of red blood cells. Option C is incorrect because active range of motion exercises during an acute vaso-occlusive crisis would increase pain and stress on already ischemic tissues. Rest and gentle positioning are appropriate until the acute crisis resolves. Sickle cell vaso-occlusive crisis. The patient is in severe pain across multiple joints and extremities. Opioids have been given. What's the priority now? Evaluating whether those pain meds are actually working. Pain control is the absolute cornerstone of sickle cell crisis management. If the opioids aren't providing relief, the dose needs adjusting, or the medication needs changing. You can't just give pain meds and walk away. You have to circle back and assess effectiveness. Now, cold packs might seem helpful for swollen joints, but in sickle cell disease, cold causes vasoconstriction. That reduces blood flow and oxygen delivery to tissues that are already ischemic from sickled cells blocking the vessels. Cold makes sickling worse. Fluid restriction is the opposite of what these patients need. Aggressive IV hydration is a cornerstone of crisis treatment. It improves blood flow and reduces blood viscosity, which helps unsickle cells. And active range of motion during an acute crisis that would increase pain and stress on already damaged ischemic tissues. Rest is appropriate until the crisis resolves. Here's a WGU D454 OA exam tip for you. In sickle cell crisis, after giving pain medication, the next step is always evaluating its effectiveness. And remember, cold and fluid restriction are both contraindicated. Recall Hook, sickle cell crisis care is HEP. Hydrate, evaluate pain, protect from cold. 21. A nurse is caring for a patient with immune thrombocytopenic purpura who has a platelet count of 42,000. The provider orders a platelet transfusion. Before hanging the platelets, the nurse should take which action based on understanding of this specific autoimmune condition? A. Administer prophylactic acetaminophen and diphenhydramine. B. Verify the patient's blood type for cross-match compatibility. C. Consult the provider about appropriateness of transfusion. D. Infuse normal saline rapidly to prevent a transfusion reaction. Do you know the answer? Correct answer, C. Consult the provider about appropriateness of transfusion. Explanation. Option C is correct because in immune thrombocytopenic purpura, the body actively destroys platelets through autoimmune antibodies. Transfused platelets will be rapidly destroyed, making transfusion ineffective unless actively life-threatening bleeding exists. Option A is incorrect because while pre-medication may be standard for some transfusions, the critical issue in this scenario is questioning whether platelet transfusion is appropriate at all. In ITP, the autoimmune process destroys transfused platelets quickly. Option B is incorrect because while blood type verification is always part of transfusion safety, it is not the priority concern here. The fundamental question is whether platelet transfusion is therapeutically appropriate for this autoimmune condition. Option D is incorrect because rapid normal saline infusion before transfusion does not prevent reactions and is not standard protocol. The priority concern is the clinical appropriateness of giving platelets that will be immediately destroyed by autoantibodies. This question trips up a lot of students because the instinct is to just hang the platelets as ordered. But hold on, the patient has ITP, immune thrombocytopenic purpura. That changes everything. In ITP, the patient's own immune system is churning out antibodies that tag platelets for destruction. Their body is a platelet shredding machine right now. So if you transfuse platelets into this patient, those autoantibodies will destroy the transfused platelets just as fast as the patient's own. It's pouring water into a bucket with a hole in the bottom. That's why the nurse should consult the provider before hanging them. Platelet transfusions in ITP are generally reserved for counts below 10,000 or active life-threatening bleeding. At 42,000, this patient doesn't meet that threshold. Pre-medication with acetaminophen and diphenhydramine is standard transfusion practice, but it's not the priority concern here. The question is whether to transfuse at all. Blood type verification is always done, but again, the bigger issue is appropriateness. And rapid saline infusion before a transfusion isn't standard protocol and doesn't prevent reactions. Here's a WGU D454 OA exam tip for you. ITP plus platelet transfusion order equals question the order. The autoimmune destruction makes transfusion futile unless the patient is actively dying from hemorrhage. Recall hook. ITP means I take out platelets. Don't pour in what the body tears apart. 22. A nurse is caring for a patient with thrombocytopenia and notices the patient has small pinpoint purplish red spots scattered across the chest and arms. The patient also reports bleeding gums when brushing teeth. Which assessment finding would require the most urgent notification to the provider? A. The patient is increasingly difficult to arouse. B. The patient reports a new headache this morning. C. The patient notices increased bruising on forearms. D. The patient has blood-tinged saliva after eating. Do you know the answer? Correct answer? A. The patient is increasingly difficult to arouse. Explanation. Option A is correct because difficulty arousing a thrombocytopenic patient suggests possible intracranial hemorrhage, which is the most life-threatening complication. Altered consciousness requires immediate provider notification and urgent neurological evaluation to rule out bleeding. Option B is incorrect because while a new headache in a thrombocytopenic patient warrants monitoring, it has many potential causes. Difficulty arousing represents a more advanced and immediately dangerous neurological deterioration, suggesting active intracranial bleeding. Option C is incorrect because increased bruising on the forearms is an expected finding in thrombocytopenia and reflects the low platelet count. While documented, this does not represent the acute, life-threatening emergency that altered consciousness does. Option D is incorrect because blood-tinged saliva after eating likely reflects minor mucosal bleeding from the gums, which is a common and expected manifestation of low platelets. It does not carry the same urgency as declining consciousness. The patient here has thrombocytopenia, low platelets, petechia across the chest and arms, bleeding gums, all expected findings when platelets are tanking, but the question asks which finding needs the most urgent notification. The answer is the patient who is increasingly difficult to arouse. That altered level of consciousness in a thrombocytopenic patient should make your blood run cold because it suggests intracranial hemorrhage. When platelets are critically low, bleeding can happen anywhere, including inside the skull. And a brain bleed is the single most lethal complication of thrombocytopenia. A new headache is worth monitoring, sure, but headaches have 100 causes. Difficulty arousing is a much more advanced and ominous neurological sign. It means the brain is being compressed. Increased bruising on the forearms? That's expected with low platelets. Document it and move on. Blood-tinged saliva after eating? Minor mucosal bleeding from the gums. Common, expected, not life-threatening. Here's a WGU D454 OA exam tip for you. In any thrombocytopenia question, the most dangerous finding is always altered mental status or decreased level of consciousness. It points to intracranial hemorrhage. Recall hook. Thrombocytopenia plus can't wake up equals brain bleed. TCW. Think cranial warning. 23. A patient with haemophilia type A experiences sudden severe pain and visible swelling in their right knee joint after bumping it against a table. The nurse recognizes this as hemothrosis. What is the most appropriate initial nursing intervention for this acute bleeding episode? A. Apply warm compresses to promote circulation. B. immobilize the affected joint immediately. C. Begin passive range of motion exercises gently. D. Administer aspirin for pain and inflammation. Do you know the answer? Correct answer. B. Immobilize the affected joint immediately. Explanation. Option B is correct because immobilizing the joint during active hematologic prevents further trauma and bleeding into the joint space. Movement during active bleeding worsens hemorrhage and causes additional damage to the synovial tissue. Option A is incorrect because warm compresses cause vasodilation, which increases blood flow to the area and worsens active bleeding. Cold application would be more appropriate to promote vasoconstriction and reduce hemorrhage into the joint. Option C is incorrect because range of motion exercises during active joint bleeding would increase trauma to the already hemorrhaging synovial space. Exercise is appropriate only during rehabilitation after the acute bleeding episode is completely resolved. Option D is incorrect because aspirin inhibits platelet function and would significantly worsen bleeding in a haemophilia patient. Aspirin and all other antiplatelet medications are strictly contraindicated in patients with haemophilia and bleeding disorders. Haemophilia type A, factor VIII deficiency, and the patient just banged their knee against a table. Now the knee is swelling fast with severe pain. That's hematologic, bleeding directly into the joint space. The first thing you do is immobilize that joint. Any movement during active bleeding forces more blood into the synovial space, causing more swelling, more damage, and more pain. Lock it down. Now check the distractors because they're all harmful. Warm compresses cause vasodilation. You'd be increasing blood flow to an area that's already hemorrhaging. That's exactly backwards. Cold would be more appropriate. Range of motion exercises during active joint bleeding. You'd be grinding damaged tissue together while blood is still pouring in. Exercises for rehab after the bleeding stops completely. And aspirin, this one should jump off the page as wrong. Aspirin inhibits platelet function. Giving aspirin to a haemophilia patient who is actively bleeding is like throwing gasoline on a fire. Aspirin is absolutely contraindicated in haemophilia. Here's a WGU D454 OA exam tip for you. Hematologic in haemophilia equals immobilize first. No heat, no movement, definitely no aspirin. Recall hook. Rice without the E during active bleeding. Rest, ice, compression, but no exercise until the bleeding stops. 24. A nurse is monitoring a critically ill patient with septicemia who develops oozing blood from intravenous sites, venipuncture wounds, and incision lines simultaneously. Laboratory results show elevated D-dimer, decreased platelets, prolonged clotting times, and decreased fibrinogen. What condition is developing? A. Immune thrombocytopenic purpura flare. B. Heparin-induced thrombocytopenia reaction. C. Vitamin K deficiency from poor nutrition. D. Disseminated intravascular coagulation. Can you guess the answer? Correct answer, D. Disseminated intravascular coagulation. Explanation. Option D is correct because oozing from multiple sites in a septic patient with elevated D-dimer, decreased platelets, prolonged clotting times, and low fibrinogen is the classic laboratory and clinical presentation of disseminated intravascular coagulation. Option A is incorrect because immune thrombocytopenic purpura involves isolated platelet destruction from autoantibodies and does not produce the widespread consumption of clotting factors, elevated D-dimer, and decreased fibrinogen seen in this scenario. Option B is incorrect because heparin-induced thrombocytopenia requires prior heparin exposure and primarily causes thrombosis rather than diffuse hemorrhage. The laboratory pattern of consumed clotting factors points specifically to disseminated intravascular coagulation. Option C is incorrect because vitamin K deficiency affects clotting factor production but does not cause the characteristic combination of thrombocytopenia, elevated D-dimer, and decreased fibrinogen. This complete consumption pattern indicates a systemic coagulation process. This is the classic DIC presentation, and you need to recognize it immediately. A critically ill septic patient starts oozing blood from IV sites, venipuncture wounds, and incision lines all at once. The labs tell the story: elevated D-dimer, decreased platelets, prolonged clotting times, and decreased fibrinogen. That's disseminated intravascular coagulation. The clotting cascade has gone haywire. Here's the paradox that makes DIC so dangerous. The body is clotting and bleeding at the same time. Microscopic clots form everywhere, consuming platelets and clotting factors. Once those are used up, the patient bleeds from every possible site because there's nothing left to form clots with. Sepsis is one of the most common triggers. ITP doesn't fit because ITP involves isolated platelet destruction, not this full consumption picture with low fibrinogen and prolonged clotting times. HIT requires prior heparin exposure and mainly causes clots, not diffuse oozing. Vitamin K deficiency affects factor production, but doesn't give you the D-dimer elevation and fibrinogen crash. Here's a WGU D454 OA exam tip for you. Oozing from multiple sites plus sepsis plus elevated D-dimer plus low fibrinogen equals DIC. Every time. Recall hook. DC means dying is close if you don't catch it. Oozing everywhere in a sick patient means DIC. 25. A nurse receives a patient from the blood bank for a red blood cell transfusion. Within 15 minutes of starting the infusion, the patient reports sudden back pain, develops shortness of breath, and the heart rate climbs to 124. What should the nurse do first? A. Slow the transfusion rate and monitor closely. B. Administer prescribed diphenhydramine immediately. C. Disconnect the transfusion and infuse normal saline. D. Obtain a full set of vital signs and continue monitoring. Can you guess the answer? Correct answer, C. Disconnect the transfusion and infuse normal saline. Explanation. Option C is correct because back pain, dyspnea, and tachycardia within minutes of starting a transfusion indicate an acute hemolytic reaction. The transfusion must be stopped immediately and normal saline infused through new tubing. Option A is incorrect because slowing the transfusion rate during a suspected acute hemolytic reaction allows continued exposure to incompatible blood. Any hemolytic reaction requires complete and immediate disconnection of the blood product to prevent fatal complications. Option B is incorrect because diphenhydramine treats allergic reactions characterized by urticaria and itching. The presentation of back pain with dyspnea and tachycardia suggests a hemolytic reaction, which requires stopping the transfusion rather than antihistamine treatment. Option D is incorrect because continuing to monitor while the transfusion runs allows further destruction of the patient's red blood cells by incompatible donor antibodies. The priority is stopping the source of harm before any additional assessment steps. A blood transfusion is running, and within 15 minutes the patient reports sudden back pain, develops shortness of breath, and the heart rate shoots up to 124. Back pain, dyspnea, tachycardia, all within minutes of starting. That's an acute hemolytic transfusion reaction. The incompatible donor blood is being attacked by the patient's antibodies. Red cells are bursting apart, and the cascade of destruction is underway. The nurse's first action is to disconnect the transfusion immediately and start infusing normal saline through new tubing. You need to stop the incompatible blood from entering the body and maintain IV access for emergency interventions. Slowing the rate is not enough. That still allows incompatible blood to drip in. Every drop is causing more hemolysis. Diphenhydramine is for allergic reactions with hives and itching, not hemolytic reactions with back pain and respiratory distress. And just monitoring while continuing the transfusion. That lets the hemolysis keep going while you watch the patient deteriorate. Here's a WGU D454 OA exam tip for you. Back pain plus dyspnea plus tachycardia within 15 minutes of transfusion start equals acute hemolytic reaction. Stop the blood immediately The timing is the clue. Hemolytic reactions happen fast. Recall hook. Back pain during transfusion means bad blood, stop it. BDT, bad blood, disconnect, treat. 26. A nursing student asks how malignant tumours differ from benign tumours in terms of their behaviour within the body. The instructor explains that one defining characteristic separates them. Which feature is unique to malignant tumours and is not observed in benign growths? A. Ability to spread to distant organs through metastasis. B. Tendency to grow rapidly in a single location. C. Formation of a visible mass on imaging studies. D. Development of symptoms like pain and pressure. Can you guess the answer? Correct answer. A. Ability to spread to distant organs through metastasis. Explanation. Option A is correct because metastasis is the hallmark feature that distinguishes malignant tumours from benign ones. Malignant cells invade surrounding tissues and travel through blood or lymph to establish new tumour sites in distant organs. Option B is incorrect because while malignant tumours can grow rapidly, so can benign tumours. Rapid growth alone does not define malignancy. Option C is incorrect because both benign and malignant tumours can form visible masses. The ability to be detected on imaging does not differentiate them. Option D is incorrect because benign tumours can also cause symptoms like pain and pressure, especially if they press on nearby structures. Symptoms alone don't indicate malignancy. Malignant versus benign. What's the defining difference? The answer is metastasis. Malignant tumours can break away from the primary site, invade surrounding tissues, travel through the bloodstream or lymphatic system, and set up new colonies in distant organs. Benign tumours don't do this. They stay put. A benign tumour can grow large, cause symptoms, compress nerves, and cause real problems. But it won't metastasize. Rapid growth happens in both malignant and benign tumours, so speed of growth alone doesn't tell you which one you're dealing with. Both types form visible masses on imaging. A CT scan can show you a mass, but it can't tell you whether that mass will metastasize. That's why biopsy is needed. And both benign and malignant tumours can cause symptoms like pain and pressure, especially when they grow large enough to compress nearby structures. Here's a WGU D454 OA exam tip for you. If a question asks what distinguishes malignant from benign, the answer is always metastasis. Growth rate, symptoms, and imaging appearance are shared features. Only malignancy spreads to distant sites. Recall hook. Malignant means it moves. Malignant migrates and metastasizes. 27. A patient newly diagnosed with cervical cancer asks the nurse to explain their pathology report, showing a staging designation of TIS N0 M0. The patient wants to know what this means for their prognosis and whether the cancer has already spread beyond the original site. A. Cancer has spread to nearby lymph nodes only. B. The original tumour site cannot be determined. C. Further imaging is required before staging is complete. D. Cancer remains localised with no spread detected. Can you guess the answer? Correct answer. D. Cancer remains localised with no spread detected. Explanation. Option D is correct because TIS indicates carcinoma in situ, meaning cancer cells remain confined to the surface layer. N0 confirms no lymph node involvement, and M0 confirms no distant metastasis, indicating completely localised disease. Option A is incorrect because N0 specifically means that no lymph node involvement has been identified. If cancer had spread to nearby lymph nodes, the staging would reflect a higher N value, such as N1 or N2. Option B is incorrect because TIS is a specific designation, meaning in situ, confirming the tumour has been identified at its original site. The designation TX would be used when the primary tumour site cannot be assessed or determined. Option C is incorrect because a complete TNM staging designation has already been assigned with specific values for each component. This staging represents a definitive assessment, not a preliminary or incomplete evaluation requiring additional workup. The patient has a staging report that reads TIS N0 M0. Let's decode this piece by piece. TIS means carcinoma in situ. The cancer cells are sitting right on the surface layer and haven't punched through the basement membrane into deeper tissue. They haven't invaded anything yet. N0 means no lymph node involvement has been found. M0 means no distant metastasis detected. Put it all together and you get completely localized disease. The cancer is exactly where it started and hasn't gone anywhere. That's about as favorable a staging as you can get. Now eliminate the wrong answers. Cancer has not spread to nearby lymph nodes. The N0 specifically rules that out. The original tumour site is known. TIS tells you exactly where it is. If the site were unknown, the designation would be TX. And this is a complete staging, not a preliminary one. All three components have defined values. Here's a WGU D454 OA exam tip for you. TIS N0 M0 equals cancer that hasn't gone anywhere. The word in situ means in place, in position, right where it started. Recall hook. TIS means it stayed put. TIS, tumour in situ, staying in place. 28. A nurse is conducting a community health screening event and encounters a participant who smokes 1 pack of cigarettes daily and has done so for 20 years. The participant asks about cancer prevention strategies. Which nursing intervention has the greatest documented impact on reducing this person's cancer mortality risk? A. Scheduling annual low-dose chest imaging. B. Providing smoking cessation counselling today. C. Recommending daily antioxidant vitamin supplements. D. Referring for genetic cancer risk testing. Do you know the answer? Correct answer. B. Providing smoking cessation counselling today. Explanation. Option B is correct because smoking cessation counselling at every clinical encounter is the single most impactful nursing intervention for reducing lung cancer mortality. Eliminating tobacco exposure directly removes the primary modifiable carcinogenic risk factor. Option A is incorrect because while low-dose imaging screening has value for early detection in high-risk individuals, screening finds existing cancer rather than preventing it. Cessation counselling addresses the root cause of elevated cancer risk. Option C is incorrect because research has not demonstrated that antioxidant vitamin supplements reduce cancer risk in smokers. Some studies have shown potential harm from certain supplements in this population, making cessation the superior intervention. Option D is incorrect because genetic testing identifies inherited predisposition, but does not address the dominant modifiable risk factor in this scenario. This patient's 20-year smoking history represents a far greater immediate cancer risk than genetics alone. 20-year pack-a-day smoker asks about cancer prevention. What is the biggest documented impact? Smoking cessation counselling, right here, right now, at this encounter. This isn't about scanning for existing cancer. It's about eliminating the cause before cancer develops. Smoking cessation is the single most effective intervention a nurse can deliver to reduce lung cancer mortality. Period. Low-dose chest imaging can catch cancer early in high-risk individuals, and it does save lives through early detection. But detection is not prevention. You're finding tumours that already exist, not stopping them from forming. Antioxidant supplements sound appealing, but the research doesn't back them up for smokers. Some studies actually found that beta-carotene supplements increased lung cancer risk in active smokers, and genetic testing reveals inherited predisposition, which matters, but a 20-year smoking habit is a far bigger driver of this person's cancer risk than their DNA right now. Here's a WGU D454 OA exam tip for you. When a question mentions a smoker and asks about the greatest cancer impact, the answer is always cessation counselling. Screening finds cancer, cessation prevents it. Recall hook. Cessation beats screening. Stop the cause, don't just find the effect. 29. A patient has an abnormal mass detected on imaging, and the oncologist recommends a tissue sampling procedure to establish a definitive diagnosis. The patient asks the nurse why imaging alone cannot confirm whether the mass is cancerous. What is the best explanation for why this additional step is necessary? A. Imaging cannot measure tumour growth rate accurately. B. Blood tests must accompany imaging for full staging. C. Only tissue examination under a microscope confirms cancer. D. Radiation from imaging interferes with cancer cell detection. Do you know the answer? Correct answer, C. Only tissue examination under a microscope confirms cancer. Explanation. Option C is correct because a definitive cancer diagnosis requires biopsy regardless of imaging findings. Microscopic examination of tissue cells is the only way to confirm malignancy, determine cell type, grade, and guide the specific treatment approach. Option A is incorrect because while growth rate assessment can be informative, the reason imaging alone is insufficient is that it cannot determine cellular characteristics. Only direct tissue sampling reveals whether cells are truly malignant under microscopic examination. Option B is incorrect because while blood tests provide supportive information, they are not the reason a biopsy is needed. Many tumour markers lack specificity and can be elevated in non-cancerous conditions, making tissue examination the definitive requirement. Option D is incorrect because imaging radiation does not interfere with cancer cell detection. The limitation of imaging is that it shows structural abnormalities without providing cellular-level information needed to confirm whether a mass is malignant. A mass shows up on imaging, and the patient wants to know why the scan alone can't confirm cancer. Fair question. Here's the answer. Only tissue examination under a microscope can definitively confirm cancer. Imaging shows you that something is there. It can tell you the size, shape, location, and whether it's solid or fluid-filled. What it can't do is tell you whether those cells are malignant. You need a pathologist to look at actual tissue under magnification to determine the cell type, the grade, and whether the cells are behaving like cancer. That's the biopsy. Tumour growth rate measurement is informative, but doesn't explain why a biopsy is needed. It's about cellular characteristics, not speed. Blood tests provide supporting data, and tumour markers can be useful clues, but they lack specificity. PSA is elevated in prostate cancer, but also in benign prostatic hyperplasia. And radiation from imaging interfering with detection. That's just made up. Imaging radiation doesn't affect the ability to identify cancer cells. Here's a WGU D454 OA exam tip for you. Definitive cancer diagnosis always requires biopsy. No matter what the imaging shows, no matter what the blood markers say, the answer is tissue under a microscope. Recall hook. Only biopsy confirms. OBC. If it's not biopsied, it's not confirmed. 30. A patient with advanced ovarian cancer is told that the surgeon plans to remove as much tumour as possible, but cannot guarantee complete removal, because the cancer involves vital structures. The patient asks the nurse what benefit this type of surgery provides if it cannot remove everything. A. Reducing tumour burden improves chemotherapy effectiveness. B. Removing any tissue prevents future cancer from developing. C. Partial removal eliminates the need for radiation therapy. D. Surgery alone provides a complete cure in most advanced cases. Do you know the answer? Correct answer. A. Reducing tumour burden improves chemotherapy effectiveness. Explanation. Option A is correct because debulking surgery reduces tumour mass so that subsequent chemotherapy can more effectively target the remaining smaller volume of cancer cells. Fewer remaining cells means chemotherapy has a better chance of achieving response. Option B is incorrect because removing part of a tumour does not prevent future cancer development. Debulking specifically addresses existing disease burden to enhance the effectiveness of follow-up treatments rather than preventing new cancer growth. Option C is incorrect because debulking surgery does not eliminate the need for additional treatment modalities. Patients who undergo cytoreductive surgery typically require chemotherapy afterward, and radiation may still be indicated depending on the cancer type. Option D is incorrect because surgery alone does not cure most advanced cancers. Debulking is explicitly acknowledged as non-curative on its own and is performed as part of a multimodal treatment plan combining surgery with chemotherapy or other therapies. The surgeon can't get all the cancer out because it's wrapped around vital structures. The patient wants to know why bother with partial removal. The answer is debulking, removing as much tumour as possible to improve the effectiveness of chemotherapy that follows. Think of it this way: chemotherapy has to kill every cancer cell to work. If you've got a massive tumour, the drugs have to penetrate deep and kill billions of cells. But if the surgeon takes out 90% of the mass first, chemotherapy only has to mop up 10%. Fewer cells means better drug penetration, better kill rates, and better outcomes. Debulking doesn't prevent future cancer. It's dealing with what's there right now. It doesn't eliminate the need for radiation either. Most patients who get debulking still need chemo and sometimes radiation afterward, and surgery alone almost never cures advanced cancer. Debulking is one piece of a multimodal treatment plan. Here's a WGU D454 OA exam tip for you. Debulking surgery equals reducing tumour bulk to make chemo more effective. If a question asks about partial tumour removal, the benefit is always about improving response to subsequent treatment. Recall hook. Debulk so drugs can do their job. DDD, cut the mass, then kill the rest. 31. A nurse is taking a detailed history from a patient referred for breast cancer risk assessment. The nurse needs to identify factors that increase lifetime estrogen exposure. Which question is most pertinent to accurately evaluate this patient's hormonal risk profile for breast cancer development? A. How many servings of red meat do you eat weekly? B. Do you have a history of ovarian cyst removal? C. What medications do you currently take for allergies? D. At what age did you have your first menstrual period? Do you know the answer? Correct answer, D. At what age did you have your first menstrual period? Explanation. Option D is correct because early menarche increases lifetime estrogen exposure, which is a well-established risk factor for breast cancer. Knowing the age of first menstruation directly quantifies the duration of hormonal exposure the breast tissue has experienced. Option A is incorrect because while dietary habits can influence overall cancer risk, red meat consumption does not directly assess lifetime estrogen exposure. The question asks specifically about hormonal risk profiling, which requires reproductive history information. Option B is incorrect because a history of ovarian cyst removal does not directly correlate with increased lifetime estrogen exposure or breast cancer risk assessment. Ovarian cysts are common and usually benign, and their removal does not change hormonal exposure patterns. Option C is incorrect because allergy medications do not affect estrogen levels or breast cancer risk assessment. This question gathers irrelevant information when the goal is specifically evaluating hormonal risk factors for breast cancer development. Breast cancer risk assessment. And the question asks which factor best evaluates lifetime estrogen exposure. The answer is age of menarche, the first menstrual period. Here's the logic. The longer a woman's body produces estrogen, the longer breast tissue is exposed to its growth-promoting effects. Early menarche, say age 10 instead of age 14, means 4 extra years of estrogen exposure. That cumulative hormonal load directly increases breast cancer risk. It's the same reason late menopause is also a risk factor. More years of cycling equals more estrogen exposure. Red meat consumption is a general dietary risk factor, but doesn't directly measure estrogen exposure. A history of ovarian cyst removal is common and benign. It doesn't change the hormonal exposure profile. allergy medications have nothing to do with estrogen levels or breast cancer risk whatsoever. Here's a WGU D454 OA exam tip for you. Breast cancer hormonal risk assessment always ties back to estrogen exposure duration. Menarche age, menopause age, nulliparity, hormone replacement therapy. These are the data points. Recall hook. Early menarche means extra estrogen exposure. ME. The earlier it starts, the longer the exposure. 32. A patient undergoes a modified radical mastectomy with axillary lymph node dissection on the right side. On the first post-operative day, a new nurse enters the room to start an intravenous line and reaches for the patient's right arm. What should the supervising nurse do immediately? A. Allow the procedure and document the site used. B. Ask the patient which arm they prefer for the line. C. Redirect to use the left arm and explain the restriction. D. Contact the provider for specific arm access orders. Can you guess the answer? Correct answer. C. Redirect to use the left arm and explain the restriction. Explanation. Option C is correct because after axillary lymph node dissection, the affected arm must be permanently protected from blood pressures, venipunctures, and intravenous lines. These interventions increase lymphedema and infection risk in the compromised limb. Option A is incorrect because allowing venipuncture in the arm on the surgical side with lymph node dissection violates a critical post-mastectomy safety principle. Documenting the site does not mitigate the increased risk of lymphedema and infection. Option B is incorrect because patient preference does not override medical safety restrictions. The arm on the side of lymph node dissection must be protected regardless of the patient's preference to maintain lymphatic drainage and prevent complications. Option D is incorrect because contacting the provider for orders would delay necessary action and is unnecessary. The restriction against using the affected arm is a well-established nursing standard of care that does not require an individual physician order. First post-op day after modified radical mastectomy with axillary lymph node dissection on the right side. A new nurse walks in and reaches for the right arm to start an IV. The supervising nurse needs to stop this immediately and redirect to the left arm. After axillary lymph node dissection, the affected arm is permanently off limits for blood pressures, venipunctures, IVs and blood draws. The lymph nodes that normally drain fluid from that arm have been removed. Without them, the arm has compromised lymphatic drainage. Any needle stick, tourniquet or pressure cuff increases the risk of lymphedema, chronic painful swelling that can become permanent, an infection that the impaired lymphatic system can't fight properly. A sign should be posted at the bedside making this restriction visible to everyone. Allowing the procedure and just documenting it doesn't prevent the harm. Patient preference doesn't override this safety restriction. And waiting to contact the provider for orders wastes time. This is established nursing standard of care, not something requiring a physician order. Here's a WGU D454 OA exam tip for you. Mastectomy with lymph node dissection means the affected arm is permanently protected. No BP, no IV, no blood draw, no tourniquet. Recall hook. Lymph nodes gone, leave that arm alone. LL. Lymph lost, arm locked. 33. A nurse is providing education to a patient who has been a heavy smoker for 30 years and wants to know the earliest warning sign of lung cancer that most people first notice. The patient has heard that lung cancer is often caught late and wants to know what symptom to watch for. A cough that persists and does not resolve. B. Sudden unexplained weight loss over weeks. C. Progressive shortness of breath with activity. D. Recurring episodes of blood-streaked sputum. Do you know the answer? Correct answer. A cough that persists and does not resolve. Explanation. Option A is correct because a persistent cough is the most common first symptom that patients with lung cancer notice. Because smokers often attribute cough to their habit, they frequently delay seeking evaluation until the disease is advanced. Option B is incorrect because unexplained weight loss is typically a later manifestation of lung cancer, indicating advanced or metastatic disease. It is not the earliest warning sign that most patients notice before other symptoms develop. Option C is incorrect because progressive shortness of breath usually develops after the tumour has grown large enough to obstruct airways or cause pleural effusion. A persistent cough typically precedes dyspnea as the initial presenting symptom. Option D is incorrect because hemoptysis, while alarming and associated with lung cancer, is not the most common first symptom. Most patients first notice a persistent cough before blood-streaked sputum appears, making cough the earlier warning sign. 30-year heavy smoker wants to know the earliest warning sign of lung cancer. The answer is a persistent cough that won't go away. Here's the problem. Smokers cough. They cough every day, so when a cough lingers or changes character, they brush it off as just their smoker's cough acting up. That dismissal is exactly why lung cancer gets caught late. By the time other symptoms appear, weight loss, hemoptysis, dyspnea, the disease is often advanced. The cough is there first, but it hides in plain sight. Unexplained weight loss is a later sign that typically indicates the cancer has advanced or spread. Progressive shortness of breath usually develops after the tumour has grown large enough to obstruct airways or cause pleural effusion. And hemoptysis, blood-streaked sputum, is alarming when it happens, but it's not the most common first symptom. The persistent cough usually comes before blood appears. Here's a WGU D454 OA exam tip for you. Earliest lung cancer symptom equals persistent cough. Smokers ignore it because they already cough daily. That's what makes it so dangerous. It blends in. Recall hook. Cough that won't quit in a smoker means cancer check. CC, cough that changed, cancer check. 34. A nurse is conducting a skin cancer prevention seminar for a group of college students. Several participants admit to using tanning beds regularly before social events. When prioritising teaching about melanoma prevention, which modifiable risk factor should the nurse focus on most strongly with this particular audience? A. Applying sunscreen with higher protection ratings. B. Eliminating indoor tanning bed use completely. C. Wearing protective clothing during outdoor activities. D. Scheduling annual dermatology skin examinations. Do you know the answer? Correct answer, B. Eliminating indoor tanning bed use completely. Explanation. Option B is correct because tanning bed use is a modifiable behaviour this specific audience engages in, and it significantly increases melanoma risk. Focusing on a behaviour the audience can change immediately provides the most impactful and relevant prevention teaching. Option A is incorrect because while sunscreen use is important for overall skin protection, these students specifically identified tanning bed use as their primary behaviour. Addressing the known high-risk behaviour they already engage in has greater immediate impact. Option C is incorrect because protective clothing addresses outdoor sun exposure rather than the identified indoor tanning behaviour. Since these students specifically used tanning beds, targeting that modifiable risk factor takes priority over outdoor clothing recommendations. Option D is incorrect because annual skin examinations detect existing problems rather than preventing new melanoma development. Prevention teaching should prioritise eliminating the causative behaviour of tanning bed use rather than focusing solely on detection strategies. Skin cancer prevention seminar, and the audience is college students who admit they use tanning beds before social events. The question asks which modifiable risk factor to focus on most strongly. The answer is eliminating indoor tanning bed use completely. Why this over sunscreen or clothing or dermatology visits? Because you teach to your audience. These students just told you what their risky behaviour is. Tanning beds deliver concentrated UV radiation directly to the skin, and the link to melanoma is well established. This is a behaviour they can stop today. Sunscreen is important generally, but it doesn't address the identified behaviour. These students aren't asking about beach protection. They're telling you they use tanning beds. Protective clothing targets outdoor exposure, not the indoor UV bombardment happening in tanning salons. Annual skin exams detect problems that have already developed. That's secondary prevention, finding disease early. What this audience needs is primary prevention, stopping the behaviour that causes melanoma in the first place. Here's a WGU D454 OA exam tip for you. Prevention teaching targets the modifiable behaviour the patient actually engages in. When the question identifies the specific risk behaviour, your answer addresses that behaviour directly. Recall hook. Teach to the threat. TTT. Tanning beds are the threat here, so tanning beds are the target. 35. A patient who underwent radical prostatectomy 2 weeks ago reports frustration and embarrassment about involuntary urine leakage during daily activities. The nurse recognises this is a common post-operative complication. Which intervention should the nurse teach as the primary strategy to address this expected recovery challenge? A. Restricting all fluid intake after 6 in the evening. B. Wearing absorbent protective undergarments permanently. C. Requesting a prescription for anticholinergic medication. D. Performing pelvic floor strengthening exercises regularly. Can you guess the answer? Correct answer. D. Performing pelvic floor strengthening exercises regularly. Explanation. Option D is correct because pelvic floor muscle exercises, commonly known as Kegels, are the primary teaching intervention for post-prostatectomy urinary incontinence. Strengthening these muscles improves urinary sphincter control and continence over time with consistent practice. Option A is incorrect because restricting evening fluids is a general continence management tip, but does not address the underlying muscle weakness causing incontinence. Pelvic floor exercises directly target the root cause of post-surgical urinary leakage. Option B is incorrect because wearing protective garments manages the symptom, but does not improve the condition. Absorbent products are a temporary coping strategy, while pelvic floor exercises work to restore actual muscle strength and continence. Option C is incorrect because anticholinergic medications address overactive bladder symptoms rather than post-surgical sphincter weakness. The primary approach to post-prostatectomy incontinence is rehabilitative exercise, not pharmacological management. 2 weeks after radical prostatectomy, the patient has urinary incontinence. He's frustrated and embarrassed. What's the primary teaching intervention? Pelvic floor strengthening exercises, Kegels. The prostate sits right at the base of the bladder, and removing it disrupts the urinary sphincter mechanism. The muscles that control urine flow have been weakened by surgery. Kegels directly strengthen those pelvic floor muscles, gradually restoring the ability to hold urine. It takes time and consistency, but it works. Restricting evening fluids is a general management tip that might reduce nighttime leakage, but it doesn't fix the underlying muscle weakness. It's a band-aid, not a treatment. Absorbent undergarments manage the symptom. They catch the leakage but do nothing to improve continence. And anticholinergic medications treat overactive bladder, which is a different problem. Post-prostatectomy incontinence comes from sphincter weakness, not bladder spasms. The treatment is rehabilitative exercise, not medication. Here's a WGU D454 OA exam tip for you. Post-prostatectomy incontinence equals pelvic floor exercises, also called Kegels. The question might use any of those terms, but the concept is the same. Strengthen the muscles that surgery weakened. Recall hook. Prostate out, pelvic floor exercises in. PP, post-prostatectomy, means pelvic floor priority. 36. A patient receiving chemotherapy asks the nurse why they need multiple treatment cycles instead of receiving one large dose that would destroy all the cancer at once. The nurse explains the biological reason related to how cancer cells behave differently at various points in their growth cycle. A. Single large doses cause permanent immune system damage. B. The liver can only metabolize limited drug amounts daily. C. resting cancer cells resist chemotherapy and must be targeted later. D. Insurance regulations require treatments to be spread across weeks. Do you know the answer? Correct answer, C. Resting cancer cells resist chemotherapy and must be targeted later. Explanation. Option C is correct because cells in the G0 resting phase are not actively dividing and are resistant to most chemotherapy agents. Multiple cycles are needed to target cells as they re-enter active division phases over time. Option A is incorrect because while myelosuppression is a real concern, it is not the biological reason for multiple cycles. The rationale relates to catching resting cancer cells as they cycle back into active division, where they become vulnerable to treatment. Option B is incorrect because hepatic metabolism capacity is not the primary reason for multiple chemotherapy cycles. The fundamental issue is that dormant cancer cells in the resting phase cannot be killed by agents that target actively dividing cells. Option D is incorrect because treatment scheduling is determined by cancer biology and pharmacological principles, not administrative or insurance regulations. The medical rationale for multiple cycles is rooted in cell cycle dynamics and tumour growth patterns. Why does chemotherapy require multiple cycles? The patient thinks one big blast should wipe out everything. The biological answer is the G0 resting phase. Not all cancer cells are dividing at the same time. Some are actively cranking through the cell cycle, G1, S phase, G2 mitosis. And those are the ones chemotherapy kills. But a chunk of cells are sitting in G0, doing absolutely nothing. They're dormant. They're not dividing, not synthesizing DNA, not doing any of the things chemo targets. So the drug passes right over them. But here's the thing. Those resting cells will eventually wake up and re-enter the cell cycle. When they do, the next round of chemo catches them. That's why you need multiple cycles. To pick off cells as they cycle back into active division, immune system damage from large doses is a real concern, but that's a side effect problem, not the biological rationale. Liver metabolism capacity doesn't drive the scheduling logic. And insurance regulations, that's just absurd. Treatment timing is based on tumour biology, not billing codes. Here's a WGU D454 OA exam tip for you. G0 equals resting equals resistant to chemo. Multiple cycles catch cells as they leave G0 and start dividing. Recall hook. G0 means go to sleep. Chemotherapy can't reach you there. Wake up, and the next cycle gets you. 37. A patient undergoing chemotherapy has a temperature reading of 38.2 degrees Celsius. The nurse knows this patient's white blood cell count was critically low on yesterday's laboratory results. What is the most appropriate immediate nursing action for this clinical situation? A. Obtain cultures and notify the provider immediately. B. Administer prescribed acetaminophen and recheck in 1 hour. C. Apply cooling blankets and increase oral fluid intake. D. Document the finding and continue routine monitoring. What do you think is the answer? Correct answer. A. Obtain cultures and notify the provider immediately. Explanation. Option A is correct because fever in a neutropenic chemotherapy patient is a medical emergency requiring immediate cultures and rapid antibiotic initiation within 1 hour. Delayed treatment in immunocompromised patients can result in overwhelming fatal sepsis. Option B is incorrect because simply treating the fever with acetaminophen and rechecking later dangerously delays the critical assessment and antibiotic therapy this immunocompromised patient needs. Fever may be the only sign of life-threatening infection. Option C is incorrect because cooling measures address the symptom without investigating the underlying cause. In a neutropenic patient, fever demands urgent cultures and antibiotics because the compromised immune system cannot fight infection without pharmacological support. Option D is incorrect because documenting and continuing routine monitoring is dangerously inadequate for a febrile neutropenic patient. This situation requires immediate escalation because the patient's immune system cannot mount an adequate defense against pathogens. Temperature of 38.2 in a chemotherapy patient whose WBCs were critically low yesterday. This is febrile neutropenia, and it's a medical emergency. In a patient with a gutted immune system, fever may be the only sign of infection. There's no pus because there aren't enough white cells to make pus. There's no redness because the inflammatory response can't mount properly. Fever is sometimes the entire clinical picture. The nurse needs to obtain cultures and notify the provider immediately. Antibiotics must start within 1 hour of fever onset in neutropenic patients. Waiting any longer allows bacteria to multiply unchecked in a body that has no defences. Giving acetaminophen and rechecking in an hour treats the number on the thermometer but ignores the infection that's causing it. That delay could be fatal. Cooling blankets and oral fluids are supportive measures that address comfort, not the source of infection. And documenting with routine monitoring? In a neutropenic patient, that kind of passivity can kill. Here's a WGU D454 OA exam tip for you. Fever plus neutropenia equals cultures plus antibiotics within 1 hour. There is no wait and see with febrile neutropenia. Recall Hook, FNSA. Febrile neutropenia means cultures and antibiotics. Fast. 38. A patient receiving external beam radiation to the abdomen develops dry, flaking skin over the treatment area and asks the nurse what they can safely apply for comfort. The nurse also needs to reinforce skincare precautions specific to the irradiated area. Which product is appropriate for this patient to use? A. Ice packs wrapped in cloth for 20-minute intervals. B. Fragrance-free moisturizing lotion with alcohol base. C. Petroleum-based ointment applied thickly before treatments. D. Pure aloe vera gel applied gently to the affected area. Do you know the answer? Correct answer, D. Pure aloe vera gel applied gently to the affected area. Explanation. Option D is correct because aloe vera gel is recommended for dry desquamation from radiation therapy. It soothes irritated skin without interfering with treatment delivery and provides gentle moisture to the radiation-damaged treatment area. Option A is incorrect because ice packs are contraindicated on irradiated skin because extreme temperature changes can worsen tissue damage. Radiation-treated skin is fragile and requires gentle care without thermal extremes that compromise healing. Option B is incorrect because alcohol-based products cause further drying and irritation to already compromised radiation-treated skin. The radiation has damaged sebaceous glands, and alcohol would strip any remaining moisture and worsen desquamation. Option C is incorrect because thick, petroleum-based ointments can create a bolus effect during radiation treatments, increasing skin dose and worsening damage. Heavy occlusive products should be avoided on skin in the active treatment field. The patient is getting external beam radiation to the abdomen, and the skin over the treatment area is dry and flaking. That's dry desquamation, the first stage of radiation skin damage. They want to know what they can safely apply. The answer is pure aloe vera gel. Aloe soothes the irritation, provides gentle moisture, and doesn't interfere with treatment delivery. It's the go-to recommendation for dry desquamation. Ice packs are contraindicated on irradiated skin. Radiation-treated skin is fragile, and extreme temperature changes can worsen tissue damage. No ice, no heating pads. Thermal extremes are off the table. Alcohol-based products would strip whatever moisture is left from already compromised skin. Radiation damages the sebaceous glands, so the skin is already drier than normal. Adding alcohol makes it worse. Thick petroleum-based ointments create what's called a bolus effect during radiation treatments. The ointment layer increases the radiation dose to the skin surface, making the damage worse. Heavy occlusive products need to stay away from the treatment field. Here's a WGU D454 OA exam tip for you. Dry desquamation from radiation equals aloe vera gel. No ice, no alcohol products, no thick ointments. Recall Hook. Aloe for all radiation skin. AA. Aloe is always the answer for radiation desquamation. 39. A nurse is supervising a nursing student who has been chatting at the bedside of a patient with a temporary cervical radiation implant for 30 minutes. The student is standing close to the patient and showing photos on their phone. What action should the supervising nurse take regarding radiation safety? A. Allow the visit to continue since body fluids are not radioactive. B. Intervene and limit the student's time near the radiation source. C. Ask the student to wear a lead apron and continue the conversation. D. Redirect the student to stand behind a portable radiation shield. Do you know the answer? Correct answer. B. Intervene and limit the student's time near the radiation source. Explanation. Option B is correct, because radiation safety requires minimizing time spent near patients with temporary radioactive implants. 30 minutes of close bedside contact exceeds safe exposure limits, and the supervising nurse must intervene to protect the student. Option A is incorrect because while body fluids from implant patients are generally not radioactive, the radiation source itself emits continuous exposure to anyone nearby. Time limitation is a fundamental radiation safety principle that applies regardless of fluid status. Option C is incorrect because simply adding a lead apron does not adequately address the prolonged close exposure that has already occurred. The priority principle is minimizing time at bedside, and 30 minutes of social conversation exceeds appropriate exposure duration. Option D is incorrect because repositioning behind a shield addresses distance and shielding principles, but does not address the time already spent in close proximity. The supervising nurse must first remove the student from the exposure and then reinforce time limitation principles. A nursing student has been standing at the bedside of a patient with a temporary cervical radiation implant for 30 minutes, chatting and showing photos on their phone. The supervising nurse needs to intervene and limit that student's time near the radiation source. Radiation safety is built on 3 principles: time, distance, and shielding. Time is the one being violated here. 30 minutes of close social contact with an implant patient is too long. The exposure is cumulative, and the student is receiving continuous radiation dose the entire time they're standing there. Now, it's true that body fluids from implant patients are generally not radioactive, but that fact is irrelevant. The radiation source itself is what's dangerous, not the fluids. Adding a lead apron doesn't fix the problem either, because shielding alone doesn't undo the 30 minutes of exposure that already happened. And it doesn't address the fundamental issue of excessive time. Repositioning behind a shield addresses distance and shielding, but still doesn't address the time that's already been spent. The supervising nurse needs to pull the student out and teach the time principle. Here's a WGU D454 OA exam tip for you. Radiation safety questions test the 3 principles: time, distance, shielding, and which one is being violated. Read the scenario and identify the violation. Here it's time. Recall hook, TDS, time, distance, shielding. Minimize time first. 40. A patient receiving chemotherapy reports that food tastes metallic and unpleasant, making it difficult to eat enough to maintain their weight. The nurse is planning nutritional interventions to support adequate caloric intake during treatment. Which strategy should the nurse recommend? A. Force the patient to eat disliked foods for balanced nutrition. B. Replace all meals with high-calorie liquid supplements only. C. Offer high-protein, high-calorie foods the patient finds tolerable. D. Eliminate all seasoning to reduce sensory overstimulation. What do you think is the answer? Correct answer, C. Offer high-protein, high-calorie foods the patient finds tolerable. Explanation. Option C is correct because patients with altered taste should be offered appealing high-protein, high-calorie options they can tolerate. Forcing disliked foods during chemotherapy can create permanent food aversions that persist long after treatment ends. Option A is incorrect Because forcing patients to eat foods they find unpleasant during chemotherapy can create lasting food aversions. This approach is counterproductive and may worsen the nutritional deficit by making the patient associate eating with negative experiences. Option B is incorrect because replacing all meals with liquid supplements eliminates the variety and satisfaction of eating, which can further decrease appetite and intake. Supplements should complement rather than completely replace food when oral intake is possible. Option D is incorrect because eliminating all seasoning may make food even blander and less appealing to a patient already experiencing taste distortion. Mild seasoning adjustments and experimenting with different flavors can actually help improve the eating experience. Chemotherapy has wrecked this patient's taste buds. Everything tastes metallic and awful, and they can't eat enough to maintain their weight. The right approach is to offer high-protein, high-calorie foods that the patient actually finds tolerable. You're working with what the patient can stomach, not against them. Protein and calories are the priorities because the body needs fuel for healing and immune function during treatment. Forcing patients to eat foods they find disgusting during chemo is a terrible idea. It creates permanent food aversions. The brain links the taste of that food with the nausea and misery of treatment, and the patient may never eat that food again, even years after chemo ends. You lose that food from their diet forever. Replacing all meals with liquid supplements strips away variety and the satisfaction of eating. Supplements should complement meals, not replace them entirely. Patients need to maintain as normal an eating pattern as possible, and eliminating all seasoning makes bland food even blander. When taste is already distorted, sometimes experimenting with different flavors, citrus, herbs, mild spices, actually helps. Here's a WGU D454 OA exam tip for you. Altered taste during chemo means offer tolerable high-protein, high-calorie options. Never force disliked foods. Permanent aversions are a real consequence. Recall Hook. Tolerate, don't force, TDF. Tolerable foods, don't force anything. 41. A nurse observes that a dying patient's breathing pattern has changed to alternating episodes, no breathing lasting 20 seconds or more, followed by periods of deep, rapid breaths. The family is alarmed and asks if the patient is suffocating. How should the nurse document and explain this breathing pattern? A. Agonal breathing indicating imminent cardiac arrest. B. Stridor from upper airway obstruction requiring intervention. C. Kussmaul respirations from metabolic acidosis buildup. D. Cheney-Stokes respirations as a normal end-of-life change. What do you think is the answer? Correct answer, D. Cheney-Stokes respirations as a normal end-of-life change. Explanation. Option D is correct because alternating periods of apnea, lasting 20 or more seconds, followed by deep, rapid breathing describes Cheney-Stokes respirations. This is a recognised and expected breathing pattern that commonly occurs as body systems progressively slow near death. Option A is incorrect because agonal breathing consists of irregular gasping breaths occurring at the very end of life and does not follow the rhythmic alternating pattern of apnea and deep breathing described. Agonal respirations lack the cyclical predictability of Cheney-Stokes. Option B is incorrect because stridor produces a high-pitched sound from upper airway, narrowing, and requires assessment for obstruction. The pattern described shows cyclic apnea and hypopnea without mention of audible stridor or signs of airway blockage. Option C is incorrect because Kussmaul respirations are deep, rapid, and continuous breaths driven by metabolic acidosis, typically seen in diabetic ketoacidosis. They do not include the characteristic alternating apneic pauses described in this scenario. The family is panicking because their dying loved one's breathing keeps stopping and starting. 20 seconds of nothing, no breathing at all. Then suddenly deep, rapid breaths. Then it fades back to silence again. Over and over in a cycle. This is Cheney-Stokes respirations, and it's a normal expected change as the body shuts down near the end of life. The brainstem's respiratory center is losing its ability to regulate breathing smoothly, so it overcorrects in both directions. Too much, then not enough, then too much again. The nurse should document this as Cheney-Stokes and explain to the family that the patient is not suffocating. Now separate this from the other breathing patterns. Agonal breathing is completely different. Those are irregular, sporadic gasps that happen at the very end, right before death. There's no rhythm or cycle to them. Stridor is a high-pitched sound from a narrowed upper airway. Think obstruction, not a dying pattern. That would require intervention. Kussmaul respirations are deep and rapid but continuous, driven by metabolic acidosis like you'd see in DKA. There are no apneic pauses in Kussmaul breathing. It's non-stop deep breathing. Here's a WGU D454 OA exam tip for you. Alternating apnea and deep breathing near death equals Cheney-Stokes. The cyclical on-off pattern is the giveaway. Agonal is gasping. Kussmaul is continuous deep breathing. Recall hook, Cheney-Stokes cycles. CSC. Think of it as a wave that comes and goes. 42. A woman whose mother died 4 months ago tells the nurse that she still thinks about her mother every single day and sometimes cries when she hears her mother's favourite song on the radio. She asks if something is wrong with her because she has not moved on yet. What is the most appropriate nursing response? A. Reassure that daily thoughts at 4 months reflect normal grieving. B. Recommend she schedule counselling for complicated grief. C. Suggest she avoid triggers like her mother's favourite music. D. Explain that most people recover within 3 months of loss. Do you know the answer? Correct answer. A. Reassure that daily thoughts at 4 months reflect normal grieving. Explanation. Option A is correct because thinking about a deceased loved one daily and experiencing emotional responses to reminders at 4 months is completely within the range of normal adaptive grief. The patient needs reassurance that her experience is healthy. Option B is incorrect because the grief described at 4 months is not pathological or complicated. Complicated grief involves chronic, undiminished mourning beyond the first year that disrupts daily functioning, which is not what this patient is experiencing. Option C is incorrect because avoiding all reminders of the deceased is not a healthy coping recommendation and may actually delay the natural grieving process. Encountering reminders and experiencing emotions is part of normal grief resolution. Option D is incorrect because there is no standard 3-month recovery timeline for grief. Suggesting that she should have moved on by now would invalidate her normal experience and potentially cause her to suppress healthy emotional processing of her loss. A woman's mother died 4 months ago. She still thinks about her mum every single day, cries when she hears her mum's favourite song, and she's worried that something is wrong with her because she hasn't moved on. The answer is reassurance. This is completely normal grief. 4 months is not a long time. There's no expiration date on missing your mother. Daily thoughts about a loved one, emotional responses to reminders like music or photos, all of this is adaptive grief doing exactly what it's supposed to do. The person is processing their loss, not stuck in it. Recommending counselling for complicated grief is premature and potentially harmful here. Complicated grief is diagnosed when mourning remains undiminished after the first year and disrupts daily functioning. 4 months of daily thoughts and occasional crying doesn't come close to that threshold. Suggesting she avoid triggers like her mother's music is actually counterproductive. Avoidance delays the grieving process. Encountering reminders and feeling emotions about them is part of how grief resolves naturally, and telling her most people recover within 3 months. That timeline doesn't exist, saying it would invalidate her experience and pressure her to suppress healthy emotions. Here's a WGU D454 OA exam tip for you. Grief questions test whether you can distinguish normal from pathological. Normal grief lasts well beyond 4 months and includes daily thoughts and crying. Pathological grief persists beyond 1 year with no improvement. Recall hook. 4 months of grief is fine. Pathological means past 1 year. FP. 4 is fine. Past a year is pathological. 43. A patient with terminal cancer who is alert and oriented tells the nurse they are not ready to die and appears restless and anxious during the night shift. The patient's family is sleeping in the waiting room. What is the most therapeutic initial nursing action in this moment? A. Wake the family so they can provide comfort and support. B. Administer prescribed sedative medication for restlessness. C. Sit at the bedside and ask what the patient needs right now. D. Reassure the patient that everything will be all right soon. Can you guess the answer? Correct. Answer. C. Sit at the bedside and ask what the patient needs right now. Explanation. Option C is correct because therapeutic presence and open-ended inquiry demonstrate genuine caring without making assumptions about what the patient needs. Sitting at the bedside provides comfort and creates space for the patient to express fears and concerns. Option A is incorrect because waking the family assumes the patient wants family involvement at this moment. The patient may have specific concerns they wish to discuss privately, and the nurse should first assess the patient's needs before involving others. Option B is incorrect because administering sedation for restlessness in a dying patient who is verbally expressing their feelings would suppress meaningful communication. The patient is alert and expressing a need, which should be explored before considering medication. Option D is incorrect because telling a dying patient that everything will be all right soon is false reassurance that dismisses their expressed fear. Therapeutic communication requires acknowledging the patient's feelings honestly rather than offering platitudes that block meaningful dialogue. It's the middle of the night. A terminally ill patient is alert, oriented, and tells you they are not ready to die. They're restless and anxious. The family is asleep in the waiting room. What do? You sit down at the bedside and ask what they need right now. That's therapeutic presence. Physically being there, making eye contact, creating space for the patient to talk about whatever is on their mind. You're not assuming, not fixing, not deflecting. You're showing up. Waking the family assumes the patient wants them there. Maybe the patient has something they want to say to the nurse privately. Maybe they don't want to burden their family at 2 a.m. Assess the patient's needs first before pulling in other people. Giving a sedative to a patient who is alert and verbally expressing their fears would chemically silence a person in the middle of trying to communicate something important. That's the opposite of therapeutic care. And telling them everything will be all right soon. They're dying and they know it. False reassurance dismisses their reality and blocks any chance of meaningful conversation. Here's a WGU D454 OA exam tip for you. Dying patient expressing fear equals therapeutic presence. Sit down, ask, listen. The answer is never sedation or false reassurance when the patient is alert and talking. Recall hook, rationale. Sit, ask, listen. That's your end-of-life communication framework. 44. A patient with a terminal illness tells the nurse during their admission assessment that they do not want to be resuscitated if their heart stops. The patient asks the nurse to make sure this wish is respected. What is the nurse's most appropriate first response to this request? A. Write the do not resuscitate order in the patient's chart. B. Ask if these wishes have been discussed with the provider. C. Contact the ethics committee for a formal consultation. D. Inform the family of the patient's stated resuscitation wishes. What do you think is the answer? Correct answer. B. Ask if these wishes have been discussed with the provider. Explanation. Option B is correct because nurses cannot independently place do not resuscitate orders. The provider must discuss resuscitation preferences with the patient and write the medical order. The nurse's role is to facilitate this critical conversation happening. Option A is incorrect because do not resuscitate orders must be written by the healthcare provider after a documented discussion with the patient. Nurses advocate for patient wishes, but do not have the authority to write this specific medical order independently. Option C is incorrect because an ethics committee consultation is not the first step when a competent patient expresses clear resuscitation preferences. The appropriate initial action is ensuring the provider is aware so the order can be properly discussed and documented. Option D is incorrect because informing the family before confirming the order exists through the provider may create conflict. The patient's autonomy and wishes should first be communicated to the medical team to establish the proper documentation and orders. The patient tells you they don't want to be resuscitated. They want you to make sure that wish is respected. What's your first response? Ask whether these wishes have been discussed with the healthcare provider. Here's the thing nurses need to remember. You cannot write a DNR order. Only the provider can do that, and it requires a documented conversation between the provider and the patient. The nurse's role is advocacy. You heard the patient's wish, and now your job is to make sure the right person knows about it, so the order can be written and documented properly. Writing the order yourself is outside nursing scope. Full stop. It doesn't matter how clear the patient's wishes are. The legal authority to write that order belongs to the physician or advanced practice provider. Calling the ethics committee is overkill here. The patient is competent and expressing a clear preference. There's no ethical dilemma to resolve. There's just a process to follow. And telling the family before the order even exists through the provider could create unnecessary conflict. The patient's autonomy comes first, and the clinical team needs to be aligned before family is notified. Here's a WGU D454 OA exam tip for you. DNR wish from a patient equals verify with provider. Nurses advocate provider's order. That's the sequence. Recall hook. Patient wishes, provider writes. PWPW. Patient's wish needs provider's writing. 45. A hospice nurse who has provided care to a terminally ill patient for 10 months is present when the patient dies peacefully. As the family gathers around the bedside crying, the nurse feels deep sadness and tears begin forming. What is the most appropriate response for the nurse in this moment? A. Leave the room immediately to maintain professional composure. B. Suppress the emotional response and focus on clinical duties. C. Request a transfer to a different unit due to emotional burnout. D. Allow tears and share the moment of grief with the family. What do you think is the answer? Correct answer. D. Allow tears and share the moment of grief with the family. Explanation. Option D is correct because crying with a family after a meaningful care relationship is a genuine and therapeutic expression of human empathy. It does not indicate professional weakness and is considered an appropriate and healing response in hospice nursing. Option A is incorrect because leaving abruptly to maintain composure prioritizes an unrealistic standard of emotional detachment over genuine human connection. The family benefits from seeing that their loved one mattered to their caregivers as well. Option B is incorrect because suppressing genuine emotion in this context serves no therapeutic purpose and may actually harm the nurse's own well-being over time. Authentic emotional expression during appropriate moments is healthy and professional in hospice care. Option C is incorrect because feeling sadness at the death of a long-term patient does not indicate burnout or unsuitability for hospice work. This emotional response reflects the depth of caring that makes hospice nursing effective and meaningful. A hospice nurse has cared for this patient for 10 months. 10 months of visits, conversations, medication adjustments, and watching someone you care about fade. The patient dies peacefully, the family gathers around crying, and the nurse feels tears forming. What should the nurse do? Cry with them. That's it. This is a genuine human moment. The nurse spent 10 months building a relationship with this patient and this family. Feeling sadness is not a sign of weakness or burnout. It's proof that the nurse showed up as a real person who cared. Leaving the room to maintain composure prioritizes an outdated idea of clinical detachment over authentic connection. The family actually benefits from seeing that their loved one mattered to the people who cared for them. Suppressing the emotion serves no one and can damage the nurse's well-being over time. Bottling up grief repeatedly leads to compassion fatigue and actual burnout, the exact opposite of what suppression is supposed to prevent. And requesting a transfer because you cried. Sadness after a 10-month patient relationship is normal. It doesn't mean hospice isn't right for you. It means you're doing hospice the way it's meant to be done. Here's a WGU D454 OA exam tip for you. Hospice nurse crying with a family equals appropriate therapeutic response. It's not burnout, not unprofessional, not a problem. It's human. Recall hook. Real tears are right in hospice. RTR, genuine emotion is the mark of good hospice care. 46. A nurse is caring for a patient whose absolute neutrophil count has dropped critically low following chemotherapy. The nurse understands that this patient's immune system cannot mount a normal defense against pathogens. Which monitoring intervention takes highest priority for early detection of infection in this vulnerable patient? A. Checking body temperature every 4 hours consistently. B. Monitoring daily weight for fluid retention changes. C. Assessing skin turgor for dehydration every shift. D. Obtaining weekly blood cultures as a routine screen. Do you know the answer? Correct answer, A. Checking body temperature every 4 hours consistently. Explanation. Option A is correct because fever may be the only sign of infection in a neutropenic patient since the depleted immune system cannot produce typical inflammatory responses like redness or pus. Frequent temperature monitoring enables earliest possible detection. Option B is incorrect because daily weight monitoring tracks fluid balance and nutritional status, but does not serve as an early infection indicator. Neutropenic patients need temperature surveillance specifically because fever is often their sole infection sign. Option C is incorrect because skin turgor assessment evaluates hydration status rather than infection risk. While important for overall care, it does not address the critical need for early infection detection in a patient with severely compromised immune defences. Option D is incorrect because weekly routine blood cultures are not standard practice for neutropenic monitoring. Cultures are obtained when fever occurs or infection is suspected, not on a scheduled weekly basis without clinical indication. The patient's absolute neutrophil count has cratered after chemotherapy. Their immune system is essentially offline. What monitoring intervention takes the highest priority? Checking body temperature every 4 hours. Here's why temperature surveillance is king in neutropenic patients. When your white blood cell count is in the gutter, your body can't produce the normal signs of infection. No pus at a wound site because there aren't enough neutrophils to create pus. No redness or swelling because the inflammatory cascade can't fire properly. The typical infection clues are all silenced. Fever may be the only signal that bacteria are multiplying inside this patient. Miss the fever and you miss the infection. And in a neutropenic patient, an undetected infection can become fatal sepsis in hours. Daily weights track fluid balance and nutrition. Useful, but they don't catch infections. Skin turgor checks evaluate hydration status, which is a different concern entirely. And weekly routine blood cultures aren't a standard approach. Cultures are drawn when fever or infection is suspected, not on a calendar schedule without clinical indication. Here's a WGU D454 OA exam tip for you. Neutropenic patient plus infection monitoring equals temperature checks every 4 hours. Fever is the canary in the coal mine, often the only warning you'll get. Recall hook. Neutropenic means check the number on the thermometer. NT. Neutropenia means thermometer priority. 47. A patient with severe neutropenia is preparing for discharge after chemotherapy. The nurse needs to provide comprehensive teaching about infection prevention at home. The patient lives with a spouse, 2 school-aged children and a cat. Which discharge instruction is most critical for preventing life-threatening infection? A. Avoid cleaning the cat's litter box due to bacterial exposure. B. Keep children home from school to reduce germ exposure. C. Report any fever immediately without waiting for other symptoms. D. Disinfect all household surfaces with bleach solution twice daily. Do you know the answer? Correct answer, C. Report any fever immediately without waiting for other symptoms. Explanation. Option C is correct because neutropenic patients must report fever immediately, since it may be the only sign of infection their compromised immune system can produce. Waiting for additional symptoms like cough or redness delays life-saving antibiotic treatment. Option A is incorrect because while avoiding the litter box is reasonable general advice for immunocompromised patients, it does not carry the same urgency as knowing to report fever immediately. Delayed fever reporting can result in fatal sepsis. Option B is incorrect because keeping children home from school is impractical and excessive. Teaching proper hand hygiene and having the patient avoid close contact with anyone who is visibly ill provides reasonable protection without disrupting family life. Option D is incorrect because twice daily bleach disinfection of all surfaces is excessive and impractical for a home setting. Standard hygiene practices, including regular hand washing, provide adequate protection without creating an unsustainable cleaning burden. Discharge teaching for a neutropenic patient, heading home to a spouse, 2 school-age kids, and a cat. The most critical instruction. Report any fever immediately without waiting for other symptoms. We keep coming back to this point because it's that important. In a neutropenic patient, fever might be the only red flag. There won't be a cough to tip you off. There won't be redness at a wound site. The immune system is too depleted to produce those classic signs. If this patient sits at home waiting for a cough or sore throat to develop before calling the doctor, the bacteria could reach septic levels before they ever pick up the phone. Avoiding the cat's litter box is reasonable advice for any immunocompromised person. Cat feces can carry toxoplasmosis and harmful bacteria, but it's a secondary precaution, not the single most critical teaching point. Keeping kids home from school is impractical and excessive. Hand hygiene and avoiding visibly sick contacts is the realistic approach. And bleach cleaning every surface twice a day is an unsustainable burden that standard hygiene easily replaces. Here's a WGU D454 OA exam tip for you. Neutropenic discharge teaching always comes back to fever reporting. If the exam gives you 4 good-sounding instructions, the one about immediate fever reporting wins every time. Recall hook. Fever first, call fast, FFCF. In neutropenia, fever is your fire alarm. 48. A patient receiving chemotherapy develops severe neutropenia, and the provider prescribes filgrastim to be administered at home via self-injection. The patient asks the nurse how they will know if the medication is actually working to protect them from infection. Which laboratory value best measures the effectiveness of this specific medication? A. Total white blood cell count on routine complete blood count. B. Serum immunoglobulin levels drawn monthly. C. Erythrocyte sedimentation rate trending over time. D. Absolute neutrophil count on follow-up laboratory work. Do you know the answer? Correct answer, D. Absolute neutrophil count on follow-up laboratory work. Explanation. Option D is correct because filgrastim specifically stimulates neutrophil production in the bone marrow. The absolute neutrophil count directly measures the specific cell line this medication targets, making it the most precise indicator of therapeutic effectiveness. Option A is incorrect because the total white blood cell count includes multiple cell types, such as lymphocytes, monocytes, and eosinophils, in addition to neutrophils. A change in total white blood cell count may not accurately reflect the filgrastim's effect on neutrophils. Option B is incorrect because serum immunoglobulin levels measure antibody production, which is not the direct target of filgrastim. These levels would not indicate whether filgrastim is effectively increasing neutrophil production. Option C is incorrect because erythrocyte sedimentation rate is a non-specific marker of inflammation. It doesn't directly reflect neutrophil count or filgrastim's effect on neutrophil production. Filgrastim has been prescribed for a neutropenic chemo patient, and they want to know how to tell if it's working. The lab value that answers this question is the absolute neutrophil count, the ANC. Filgrastim is a colony-stimulating factor that specifically tells the bone marrow to ramp up neutrophil production. It targets one cell line, neutrophils, and that's it. So to measure whether it's doing its job, you look at the specific count of the cells it's designed to produce. The total white blood cell count is too broad. It lumps together neutrophils with lymphocytes, monocytes, eosinophils, and basophils. The WBC could go up because lymphocytes increased, not neutrophils, and you'd think the drug is working when it isn't targeting those cells at all. The ANC strips away the noise and shows you exactly what filgrastim is doing. Serum immunoglobulin levels measure antibody production by plasma cells. That's the humoral immune system, completely unrelated to filgrastim's mechanism. ESR is a non-specific inflammation marker that tells you nothing about neutrophil production. Here's a WGU D454 OA exam tip for you. Filgrastim effectiveness equals ANC, not total WBC, not immunoglobulins, not ESR. The drug targets neutrophils, so you measure neutrophils. Recall hook. Filgrastim fixes neutrophils, so check the ANC. FFN. Filgrastim for neutrophils, measured by ANC. 49. A nurse is administering a unit of packed red blood cells to a patient when the patient suddenly develops chills, anxiety, and a low-grade fever approximately 45 minutes after the transfusion began. The patient's vital signs are otherwise stable, with no back pain or respiratory distress. Which type of transfusion reaction is most consistent with this presentation? A. Acute hemolytic reaction from blood incompatibility. B. Febrile non-hemolytic transfusion reaction. C. Transfusion-related acute lung injury developing. D. Severe anaphylactic allergic reaction to donor proteins. What do you think is the answer? Correct answer. B. Febrile non-hemolytic transfusion reaction. Explanation. Option B is correct because chills, fever, headache and anxiety occurring 30 or more minutes after transfusion onset with otherwise stable vitals and no hemolytic signs characterize a febrile non-hemolytic reaction, the most common transfusion reaction type. Option A is incorrect because acute hemolytic reactions typically occur within the first 15 minutes and present with back pain, dyspnea, and tachycardia from red blood cell destruction. The absence of these hallmark symptoms makes hemolytic reaction unlikely here. Option C is incorrect because transfusion-related acute lung injury presents with acute respiratory distress, bilateral pulmonary infiltrates, and hypoxia. This patient has no respiratory symptoms, making this diagnosis inconsistent with the clinical presentation described. Option D is incorrect because anaphylactic reactions present with urticaria, bronchospasm, hypertension, and potentially cardiovascular collapse. The stable vital signs and absence of allergic symptoms like hives or wheezing make anaphylaxis an unlikely explanation. 45 minutes into a blood transfusion, the patient develops chills, anxiety, and a low-grade fever. Vitals are otherwise stable, no back pain, no respiratory distress. This is a febrile non-hemolytic transfusion reaction, and it's actually the most common type of transfusion reaction out there. The key to identifying it is the timing and what's absent. It started 30 plus minutes into the transfusion, not within the first 15 minutes. The patient has fever and chills, but no back pain, no dyspnea, no tachycardia indicating hemolysis. Vitals are stable. This is an immune response to white blood cell antigens or cytokines in the donor blood, not red cell destruction. An acute hemolytic reaction looks completely different. It hits within 15 minutes with back pain, dyspnea, and a racing heart as donor red cells get destroyed. The timing and symptom pattern here rules it out. Charlie causes acute respiratory distress with bilateral infiltrates and hypoxia. This patient has zero respiratory symptoms, so that's eliminated. Anaphylaxis brings hives, bronchospasm, hypertension, and potential cardiovascular collapse. Stable vitals with no allergic symptoms rules that out too. Here's a WGU D454 OA exam tip for you. Chills plus low fever plus stable vitals plus late onset during transfusion equals febrile non-hemolytic reaction. Compare this to hemolytic, which is early onset with back pain and hemodynamic instability. Recall Hook. Late fever with stable signs means a mild reaction. LFS, late fever, stable vitals. Think febrile non-hemolytic. 50. A patient is being discharged following a splenectomy performed as part of treatment for a hematologic disorder. The nurse understands that the spleen plays a critical role in immune defense. Which long-term teaching point is most essential for this patient to understand about their permanently increased vulnerability? A. Lifelong increased risk of infection, requiring prompt medical attention for any fever. B. Permanent need for monthly blood transfusions to replace lost blood cell filtering. C. Required daily antibiotic prophylaxis for the remainder of their natural life. D. Inability to receive any future vaccinations due to absent splenic immune function. Do you know the answer? Correct answer. A. Lifelong increased risk of infection, requiring prompt medical attention for any fever. Explanation. Option A is correct because the spleen filters encapsulated bacteria from the blood, and its removal creates permanent susceptibility to overwhelming post-splenectomy infection. Patients must seek immediate medical attention for any fever throughout their lifetime. Option B is incorrect because the spleen filters old and damaged blood cells, but monthly transfusions are not needed after removal. The liver and bone marrow compensate for most splenic filtration functions, and transfusion needs are not a standard post-splenectomy concern. Option C is incorrect because while some patients may receive prophylactic antibiotics for a period after splenectomy, lifelong daily antibiotics are not universally required. The critical teaching is recognizing and responding to fever promptly rather than indefinite antibiotic dependence. Option D is incorrect because splenectomy patients can and should receive vaccinations, particularly against encapsulated organisms like pneumococcus, meningococcus, and Haemophilus influenzae. Vaccination is strongly recommended, not contraindicated, after spleen removal. Final question. And it's about post-splenectomy teaching. The spleen is gone and this patient needs to understand what that means for the rest of their life. The single most important teaching point is that they now have a lifelong increased risk of infection and must seek immediate medical attention for any fever. The spleen's primary immune job is filtering encapsulated bacteria from the bloodstream. Organisms like Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenzae. Without the spleen, these bacteria can multiply unchecked and cause overwhelming post-splenectomy infection, which has a mortality rate that should terrify anyone into taking this seriously. Monthly blood transfusions are not needed after splenectomy. The spleen does filter old and damaged blood cells, but the liver and bone marrow pick up most of that slack. Transfusion is not a standard post-splenectomy concern. Lifelong daily antibiotics aren't universally required either. Some patients get prophylactic antibiotics for a period, but the real teaching priority is recognizing fever and acting on it immediately. And here's one that catches students off guard. Splenectomy patients can absolutely receive vaccinations. In fact, they should receive them. Vaccines against pneumococcus, meningococcus, and Haemophilus influenzae are strongly recommended, not contraindicated, after spleen removal. Here's a WGU D454 OA exam tip for you. Splenectomy equals lifelong infection risk, with immediate fever reporting as the key teaching point. Vaccinations are recommended, not forbidden. Recall Hook. Spleen gone, stay alert for fever. SSF. No spleen means seek care for fever, always.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.